I sent was MR, but it is actually focusing mostly on updates on the management of secondary or functional MR. We have a very distinguished audience and speakers and الحضور. عندنا دكتور محمد أبو الساعد نور من ألمانيا، وعندنا دكتور محمود طرينة من أبو ظبي Cleveland Clinic. Both of them are expert in the structural heart. I will be probably also presenting a few slides on the same topic, trying to address it from different angles and different aspects. It's a very complicated topic, and I think we'll be more than happy at the end. I think we're going to have 20 minutes, half an hour each, and then we'll open the floor for discussion, and I'm sure there will be lots of questions. We also don't forget we welcoming our colleagues and friends from Egypt. I think there are people from Libya and Egypt. I think we will start with Dr. Muhammad. Muhammad, the floor is yours. You want to share your slides? Everybody probably, I think at this point, maybe just mute yourself. Make sure that the presentation goes nice and smooth without interruption.
Thank you, Dr. Adel, for the invitation and for the chance that we can discuss this very important therapy. Actually, this is not a debate between surgery and interventional cardiology. This is just an introduction about how each specialty sees the difference between therapy from the other specialty. I'll speak here mainly about the interventional therapy. We have as well Dr. Mahmoud Tarina from Cleveland Clinic Abu Dhabi, and he can discuss as well these important points. And after that, we can discuss together, after the two lectures, we can discuss together the important points. As we all know, the mitral regurgitation, we have two pathologies. The first one is the primary or organic etiology, like degenerative etiology, which is most popular in the Western countries, rheumatic heart disease, which is more popular in our region, Arabic countries, Egypt and North Africa. And there is endocarditis as well, which may lead at the end to primary or organic mitral regurgitation. The second category is the secondary or functional etiology due to dilatation of the mitral ring because of different etiologies. One of them, as Dr. Adel just mentioned, atrial fibrillation and dilatation of the atrium of the ventricle, which can lead to dilatation of the ring, myocardial infarction, and there is a classification for this for different causes of ring dilatation in patients with severe mitral regurgitation. What will happen if the patient didn't receive the actual the therapy for this problem? Actually, the mortality is very high, up to 90% in 5 years in patients with untreated severe mitral regurgitation. After 2 to 3 years, maybe up to 60%, which is a short period with high mortality rate. For patients who are with low operative risk that can be operated, surgery is recommended as classification 1B in the European Society of Cardiology, or European recommendation of treatment of patients with mitral regurgitation. Asymptomatic patients should be treated, and asymptomatic patients who have a structural problem with the left ventricle should be treated as well surgically. The secondary mitral regurgitation, if the patient is symptomatic despite medical therapy, optimal medical therapy, and including the device therapy, which is the form of CRT. That's why we have to respect this recommendation, and I think we don't have any problem with this. Patients who are liable for operation, if they fulfill the criteria for surgery, should be operated upon. But the problem is when the patients are not suitable for surgery or non-operable patients. That would be the the target for interventional therapy of mitral regurgitation. How to optimize the heart failure therapy? As you know, this can affect the size of the ventricle and accordingly reduction of severe mitral regurgitation. And you can as you can see here, NT pro BNP would decrease under optimal medical therapy, and even the symptoms of the patient, the degree of mitral regurgitation would decrease as well under only optimal medical therapy. Optimal medical therapy would be beta blocker, aldosterone antagonist, ACE inhibitor, and Entresto, sodium glucose cotransporter 2 inhibitors in cases of patients have severe heart failure as part of the heart failure therapy. The patients have severe mitral regurgitation. CRT therapy would be important as well. And as you see, patients who have CRT therapy, there are a group which are good responders, but the other group are non-responders. In patients with good reaction or response to CRT therapy, this would even do some change in the prognosis of these patients with better prognosis who are responders, and the patients who are not responders, they have less survival on the time. This means you have to work at the beginning on optical medical therapy and device therapy, CRT for the patients who are liable for the CRT therapy, like patients with left bundle branch block. And when you reach this target, MR would be less, and the prognosis of the patient would be better, with better survival with the time. Repair or replacement. Actually, this is the point for Dr. Adel, but I just wanted to show these two slides just to say that after 2 years, there is still mortality after replacement or repair of about 20% in this slide, which is still a very high percentage of death, and which is very astonishing if we have after 2 years still recurrence of MR of about 45%. After 2 years, after cardiac surgery with repair or replacement, with repair, you have 45% recurrence after 2 years, which is too much less with the replacement, but still very high with repair. What about the patients who are high operative risk? If you see the mortality for patients who were operated upon, which were more than 80 years old, the mortality after 90 days, 3 months, of about 30%, which is still very high for mitral valve replacement. Who are the group of high operative risk patients? Old patients, patients with low ejection fraction, previous cardiac surgery or redo surgery, patients with COPD, pulmonary hypertension, severe liver kidney disease. I think these are the factors which are counting in the Euroscore. That's why you have to respect this with a high mortality rate, and we have to intervene. And this is the role of the interventional therapy of mitral regurgitation. Like the surgeons, we have tried in the last years to have different methods of therapy, working on the annulus with the carillon, with the cardioband, working on the cordi with the neocord. The most popular therapy in this field is the edge-to-edge repair using the MitraClip device or the Pascal device. And there is another therapy. There's another therapy with the Tendyne valve. I don't know what is this. حد
I'm not
بيكتب على
writing. Yeah,
مش عارف ايه ده. مش
I'm
عارف
not
مين اللي بيكتب
writing.
دوت.
You might have a mark.
تمام. annuloplasty therapy with the cardio band is simulating the mitral valve repair with adding a ring to the mitral ring, metal ring, and the mitral line has the same effect, trying to do some reduction of the mitral ring, but this therapy didn't have enough data and didn't spread anywhere. Neocord as well, I think it's more or less an operative therapy, which is not very distributed in the centers. Edge-to-edge repair, which is the most important therapy nowadays, even more than replacement with a Tendyne valve. Edge-to-edge repair is taking the upper hand in the therapy of the function and the primary mitral regurgitation. We have two devices in market, the MitraClip and the Pascal. With the MitraClip, as we have discussed right now with Dr. Adil before recording, we have now 4 clips, the NT, NTW, XT, XTW, which is a very good, which gives a very good option for the selection of the right device for the selected anatomy. With the NT, this is the small, short NTW, short but wide device, wider than the NT, and the same with the XT. XT is long, and XTW wide is long and wide, which gives more opportunity to choose the right clip for the specific anatomy. Like if you are dealing with primary mitral regurgitation with failure, you can, in this case, use the XTW or XT to have more grasping of this disease tissue. And if you are dealing with a pathology at the measure, you can take the NT or NTW according to the anatomy and the pathology. It gives more variation and better results with choosing the right clip. The ESC guidelines for severe chronic primary mitral regurgitation. Here you have a pathology, you have to deal with the pathology, you have symptomatic patient and start to treat the pathology directly. If the patient is operable, he can be operated upon. If the patient is not operable, here you can consider the edge-to-edge repair. But as you see, you have still recommendation of 2BB, which is not very high. But if the patient is not operable and you have primary mitral regurgitation, I think the recommendation is only to do edge-to-edge repair if the prognosis of the patient is not very bad. Otherwise, you have to consider the palliative therapy. For the secondary mitral regurgitation, we have just mentioned right now, you have the optical medical therapy, you have the device therapy with the CRT with patient with left bundle branch block, and then you assess if you can even try to solve other problems of the patient, like coronary artery disease, like aortic valve stenosis. You have to treat it first and then reassess. If the mitral regurgitation didn't improve, then you have to consider, like, before patient is operable, then you have to operate on the patient. If the patient is not operable, then you have to consider edge-to-edge repair. The COAPT trial, this is the first trial which has shown that there is a benefit from the edge-to-edge repair regarding rehospitalization, which is too much less in the device group than the control group. Death from mortality even was significant in the device group, and with a very good safety using this device. For about 6 months, we had as well 2 very important trials. The Reshape HF2 trial, which has compared edge-to-edge repair to optical medical therapy, and showed as well there is a very good benefit regarding rehospitalization for heart failure or cardiac death. And even alone for rehospitalization, there was a very good result. This means the patients are having benefit from this therapy, edge-to-edge repair, with a very good safety margin. And regarding the symptoms, the patient had very good symptomatic therapy as well. The Matterhorn study, this is a very important study because it starts to compare now edge-to-edge repair, the percutaneous therapy, to the surgical therapy, which is very important comparison. We are now getting slowly in the same era like we were before regarding TEVI, now starting to compare percutaneous therapy to surgical therapy. And as you see, the study showed non-inferiority regarding the edge-to-edge repair in comparison to the surgical therapy. As you see, regarding the major adverse events, I don't like to say superiority, but at least non-inferiority has been proven. There is a registry, MitraClip study regarding the collecting data after implanting the Pascal, which is the second device, not the Abbott device, not the MitraClip, and has showed as well safety and efficacy of the device. I brought some examples of some patients who had edge-to-edge repair even after putting a carillon, which didn't improve the result as well. Now, after edge-to-edge repair, as you see, this was very big coaptation defect. And with the new device, even was single leaflet grasping, you can now treat such complex cases, which would add to the benefit of the therapy over time. As you see, there was grasping of the posterior mitral leaflet and swinging to anterior. After that grasping of the anterior mitral leaflet, closing the device. After putting two devices, this is the final result, which I think more or less comparable to the surgical result. And even with difficult echo guiding, not suitable for having a good picture in the TEE, 3D, transesophageal echo. Even with this difficult anatomy, we could simulate the transgastric view and the grasping there, like the tricuspid valve edge-to-edge repair, and after grasping the two leaflets, closing the device, and as you see, we could have very good results, even with difficult anatomy. Patients with primary mitral regurgitation. This is the result. This means you can reach very good result, either you are dealing with primary or secondary mitral regurgitation with edge-to-edge repair. Patients who are not suitable for edge-to-edge repair, this is the Tendyne valve, which can be implanted transapical way and in cooperation with the surgeons. This is the result after the Tendyne valve. And this is the only valve, which has the CE mark in Europe. Patients who had previously ring or surgical ring or surgical valve, or patients with mitral annular calcification can have a balloon expandable valve in the position of the old mitral leaflet. Valve in valve can be done transapical or can be done transseptal as well. In summary, patients with severe mitral regurgitation, secondary mitral regurgitation, have to optimize the medical therapy. Don't forget to start with the cardiac recircularization therapy before starting to think about surgery or edge-to-edge repair. Surgery for operable patients, surgery for operable patients, surgery for operable patients. Patients who are not non-operable are liable to edge-to-edge repair or percutaneous annuloplasty. And if you have patients who has previously operated upon, then you can consider valve in valve, valve in ring. Thank you.
Thank you, Dr. Muhammad. That was a nice summary and presentation. I think, do we let people ask questions now? I think it might be worth let them open the floor for questions from the audience and
Nice
see.
presentation,
Yeah.
Dr. Muhammad. Nice
Do
presentation.
we have anybody has a question? Please raise your hand, and we'll let people take turns. Anybody have any question?
Dr. Abdurrahman has a question.
من اللي عنده رفع ايده هذا؟ لحظة مني.
محمود
ترينا.
Assalamu alaikum. Fantastic talk, Mohammed. Great job.
Thank you.
Great overview on the topic. Yeah, I think the what I would say is the take home is severe MR is a very malignant disease and it needs to be treated. Period. I think that's that severe functional MR dramatically affects prognosis, but in about 50 to 60% of the time, when you use the combination of medical therapy and CRT, that will treat it. And so that is always the first line. I think sometimes, as you know, probably in your practice as well, people will get a fresh MR, severe MR, and send them to, right away and want to address with the percutaneous or therapies. And they haven't really optimized them. They have a left bundle branch block, wide QRS, didn't do a CRT. And so those therapies actually work, and the data shows that at least more than half of patients will resolve their MR or at least push it down to mild to moderate once you optimize them. And I think that's just an important point to remember that the difference of these trials, because you showed the COAP trial and the Reshape HF2 trial, these trials used optimal medical therapy before enrolling, and the Mitra FR trial, which was a negative trial in this field, didn't. So there was no optimization before enrollment. And so I think that's kind of just, if I was going to emphasize one important takeaway point. And I think, functional MR is very different from degenerative MR. To me, functional MR is primarily a percutaneous disease, medical percutaneous disease, and not a surgical treatment unless there's other disease to be taken care of, whereas degenerative MR, because it's a leaflet problem, is primarily surgical unless they're not a good candidate. And I think that's what the Matterhorn, among other data, shows us, and we know from the outcomes from Cleveland Clinic, from series, patients don't do well with surgery with functional MR, not because the surgeons can't fix it, but the morbidity of the surgery is so high that it limits the benefit. Those are just my comments.
Any other comments before I may ask a question or two? Let's see if there's anybody else has any comment.
I think Dr.
I have
Abdurrahman
a
had this
comment.
question. Yes.
Rahman, you have a question?
Yes, I have a question. Thank you for a nice presentation, Dr. Muhammad. My question is about procedures. Why we don't see too many cases of transapical application? Why? It's all of cases covered as transseptal.
Yeah, for which type of intervention you mean?
For MitraClip.
For MitraClip,
Clip.
because the device is designed to implant it transseptal. That's number one. Number two, even with the other procedures, if you have the choice to go transseptal or transapical, even the surgeons prefer to go transseptal because transapical would be, you have still problems with the surgery, even with patients who are, most of them undergone previous operation to open the pericardium. Sometimes you have bleeding after that. You have a scar in the apex of the heart. If you can avoid transapical access, avoid it and try to go another way like transseptal for the mitral valve.
Abdurrahman, I think if you look at the mitral valve, MitraClip, it's actually a venous access. So literally, it's a very safe procedure. Like the procedure profile is very safe. And I remember, I think when I was involved, all we need to do when we remove the French, I think it was a 25 French sheet.
24.
Yusuf,
24, thanks, exactly.
24. All I put is a figure of 8, number 1 vicryl. So
Yes,
it's
we now
field
put one
puncture,
proglide.
one stitch, and there's rarely any hematomas or groin or pseudoaneurysm. So it's a very safe procedure. To convert it to become an apical, it's a big shift. And that is same story for TAVI. Transapical is dead. So I don't think people wants to open that discussion, transapical, unless you are actually doing something additional. So if you think there's a way of doing transapical procedure by approximating the papillary muscles or dealing with the cords or inserting a good size ring to enforce your repair, that might be worth
Arrhythmia.
it. But I think for the clip, it will remain transseptal to the day of judgment.
I think for all technologies, transapical, and I think in 5 years, I mean, as Mohammed mentioned, the Tendyne is the only thing available, and that's only because it's the only thing CE marked. But every single new technology in development, and this we're talking for replacements, is all transseptal and all
Exactly.
venous access. So
Yes.
transapical, we'll talk about it as a remnant in another few years, as a historical thing that used to do that, but it's surgery. It's not a percutaneous procedure.
Yeah, I think somebody at Tashani is asking about the jugular. I think yes, I think there is potential.
Can be done, but the experience is very low and only for cases who are not suitable for transfemoral venous transseptal access.
Yeah. So a question for everybody. I think when we deal with the functional MR, we know that it's similar to the AFib. If you don't get it earlier and if you don't treat it earlier, it will result in more remodeling and more overload and worse outcome.
I have one question
Can I just,
for
Abdurrahman, can I finish
Mohammed.
first? Can I finish first?
Okay, go on.
So the question is I think a lot of these patients probably get referred late. And the question to Mahmoud and Mohammed, what's the definition of failure? Like if you are on all the good medical therapy, in terms of timeline, and is it 3 months, 6 months, a year before you declared him failed medical therapy? And I know the cardiac resynchronization therapy is also part of the treatment. So can you give us in terms of timeline before when the patient was diagnosed until you say, this is enough, this is 6 months on this, now let's consult the structural team?
I think Mahmoud can answer the question.
Yeah, I mean, it's 3 months, basically. I mean, once they're on optimal therapy, 3 months. Now,
Yes.
if you have a select patient that's too sick and just can't and is not getting out of the hospital, and you really, just occasionally, but as a general rule, you have a new onset patient, you get them on the 4 pillars of heart failure therapy. You get them with somebody who has experience with heart failure patients, who optimizes their meds, and if they're candidate for CRT, and then, at least 2 to 3 months, repeat the echo, and if the MR is still there, then you treat it.
Exactly. This is exactly the same period that we leave for patients after mitral and tricuspid repair. You leave 3 months and then reevaluate the tricuspid regurg if the patient needs edge repair after mitral.
Abdurrahman, you have a question?
Yes, I have a question. My question to Dr. Muhammad. Some interventions, they say axillary axis is better than femoral axis. What your expertise in this?
You mean for TAVI? Or
Yes.
what?
No, not for TEER, for mitral.
For mitral,
Yes.
venous axis, you mean subclavian axillary?
Venous
No.
axis. Venous.
I have no experience with venous axis because most of 99% of the cases would be done transfemoral venous axis,
Femoral.
and subclavian. I think there is no rule for subclavian. If you want to go from the upper part of the body, you have the transjugular to be directly going to directed to the septum. But as I told you before, there is no big experience with transjugular edge-to-edge repair. It was done in the literature, but the experience is not that big. And the device is primarily designed to go from the transfemoral route.
I think Muhammad, Dr. Muhammad, maybe I'm not wrong, but I think even ergonomically, I think coming from the neck looking at the profile of the device, I don't know if you've seen, Abdurrahman, the MitraClip when you're trying to hold it and pass it. I think coming from the femoral, ergonomically, it's much more easy. Although
exactly.
theoretically, the access, if you come from the neck, it might be in straight shot. I remember this is the same thing with when we do direct TAVR. The TAVR cardiology team suffers a lot with
Surgery.
direct TAVR because you are actually coming at a very acute angle. And when we
Yeah.
feed the sheet and we're trying to pass the valve, everybody is sweating. And we all hope that we can come from the neck straight into the valve. So
And the
sometimes
groin is safer. The groin is safer as well.
it's safer from the
More
femoral.
safer.
And I think anesthesia probably wouldn't be happy that if you start playing from their end. And I think you're risking the contamination. And I mean, I think it's more ergonomically feasible and easy.
And you won't get enough height and the direction of the device. It's not made for both the Pascal and the MitraClip are not made for upper access.
Yeah,
exactly.
It's just would be very difficult, and you would have to do a lot of maneuvering, and so you'd make an easy procedure difficult.
We have a very good question from the audience here. And somebody with severe functional MR and severe TR and AFib, would you send this patient for surgery or clip?
Functional MR and
severe TR, functional MR, and AFib. Young patient, not young. I think patient have functional MR due to AFib, and he has a preserved EF with severe TR. Would you recommend surgical or clips?
What's the IBAB? IBAB measurement?
The question is functional MR, severe.
What's the IBAB measurement?
And preserved ejection fraction with severe TR. Let's hear from
you answer,
Dr. Adil?
I'll assess the patient for the operability. That's why we have the heart team. If the surgeon says this patient is operable, I don't have the right to intervene if I don't have good argumentation for this. If I have the real reason to say no, this patient is not operable, then I'll start with the mitral valve, reassess in 3 months the tricuspid valve, and go to for therapy of the tricuspid, either edge-to-edge repair or TTVR according to the situation. But this patient should be refused from the surgeon, or the cardiologist have a good argument for the surgeon that this patient is not operable. Otherwise, this patient should be operated upon.
Okay, Mahmoud, do you have any opinion? Because I'll
Yeah.
my opinion.
Yeah, in our practice, I mean, obviously it depends on how long-standing the AFib and what can be managed the AFib. But most of the time when they have severe MR, these are long-standing persistence, huge atriums, and not good candidates for ablation therapy. So assuming that the patient's not a candidate for ablation therapy, the mechanism of atrial MR tends to be much more annular dilatation. So clip therapy can work because clip is best for posterior restriction, which is what you get in like dilated cardiomyopathies and you get in ischemic cardiomyopathies. For atrial annular dilatation, we have done the cardioband in the past, and I think there's going to be more annuloplasty therapies that are percutaneous going to be around. They're not that ready for prime time and not easy to use, and results haven't been good. I'm a big believer in surgery, but I think functional MR, even if it's from atrial disease, doesn't do as well with surgery. And so in general, obviously every case gets discussed with heart team before we do it. But most of these patients, if they're candidate for TEER, I would proceed with TEER after consideration of AFib therapies.
So I think my opinion with this.
دكتور عادل دكتور رضا عنده سؤال.
لحظة بس خلينا نرد
دكتور
على
عادل
السؤال.
دكتور رضا عنده سؤال.
ردوا على السؤال هذا عبد الرحمن بعدين نشوف next questions. I think this patient, as Dr. Mohammed said, I think I have to look at the patient age, patient comorbidities, patient profile. The good news, which is favoring surgical option, first, it is severe MR, preserved EF, AFib. Again, have to look at the details if the atria are not over 5.5 or 6 centimeter, and he has severe TR. So I think in this patient, if he is a good surgical candidate, doesn't have any significant comorbidities, I think a chordal sparing mitral valve replacement where you don't have to excise any with a tissue valve will be an option. And that way you don't decrease the LV function post replacement. So you don't excise any leaflet. And that is one thing that surgeons lately start been implementing. And I would address AFib. I will do Cox-Maze-4 and include his appendage. And that also has been playing a role if you have a 70-60% success in getting him in sinus rhythm to improve his heart failure management and improve his EF even further. And at TR, I think you have the option. I think for us, we're sick and tired of doing ring and band because the rate of failure of TR is high. So we usually, again, we do a chordal sparing. We don't excise the tricuspid valve. We just put the largest tissue valve in. So we will end up with an MVR, TVR, and an ablation. And that is, again, after discussion with the heart team and everybody. But I don't think people will just do the TEERs and forget about the tricuspid. And especially if the AFib is a very predominant, or say it's like a year old and atrium is like 4.5 or 5 centimeter, and there's some smoke in the atrium and the appendage, then I think people will be pushing toward addressing the AFib as well. Let's see, who's the question? Rida?
Assalamu alaikum.
Salam.
Thank you all for fantastic discussion. And I'm sorry about my voice still down for the last 2 weeks. My question is to Dr. Muhammad is regarding the slide he presented showing 20% mortality post-mitral surgery. But he didn't specify if this was a special category of patients, or do you mean all comers for mitral repair? Because if that is the case, that would be extremely worrying. Can you please elaborate about that slide, where you got it from, and what patient category were you referring to? Thank you.
This is the slide, and this is, I can share it again if you allow me, Dr. Adil.
Sure. And I just want to tell Dr. Muhammad and the audience, I think in my lecture, I might be touching upon some of the questions that's being put in. It might be worth, after we're finishing with Dr. Al-Oakley question, I can proceed with mine, then we can have more time to discuss. There might be some questions would be brought up in my slides.
This is a study done in 2015 and including all types of patients with repair and replacement as well.
CTS-NET trial.
Maybe, I don't know the name of the trial.
I think this is a CTS-NET trial, yeah.
Maybe. But this is the reference, and this is the percentage. And even what really annoyed me in these slides is the rate of recurrence of mitral regurgitation.
That is with the mitral ring. That's with the annuloplasty ring, undersized.
Exactly. This is the
ischemic MR trial, Mohammed. This
was
was
not all exactly. All right. If ischemic, I would accept it.
Ischemic MR.
This was the ischemic MR randomized trial for CTS-NET trial, comparing repair versus replacement.
Yeah. Exactly. Yeah.
So the ring nobody does the ring for ischemic MR anymore. I think most people now, if you have more than moderate ischemic MR, we go straight to chordal sparing replacement because the ring will fail. Doesn't matter, undersized or oversized, whatever. But I think that I was going to comment on this in my slides as well. So let's proceed to the next presentation. Is that okay with you guys? Let me see if I can share my slides. Oops.
دكتور خلينا نسأل سؤال دكتور محمد. Dr. Muhammad, do you hear me? Okay.
Yes.
For fourth generation of a clip, you don't mention it, you don't talk a lot about it.
Okay, the difference between the old generation and the G4, the old generation and the G4, there are many differences, to be honest.
الفرق بينها وبين اللي قبلها.
بالضبط, exactly. The first generation of the MitraClip, you had only one clip. This is the NT nowadays, which is very, very rarely used, and there was no single leaflet grasping. This means you have to move the two grippers of the clip at the same time. This means you have to have the two leaflets at the same time on the clip to make the grippers down and close the device. This made a very big limitation for treating all types of mitral regurgitation. If you have a big coaptation defect, you have failure. You cannot deal with such anatomy. You have only, or most of the times, you have a small part of the leaflet, only the tip of the leaflet in the device, and when you close it, you may have just good results when you close it, and after that, you have single leaflet detachment. Now, the device has completely changed. You have 4 devices, as I told you. The most one that's used is the XT or the XTW. You have the possibility of single leaflet grasping. This means if you have a big coaptation defect, you can grasp one leaflet, the posterior, usually at the beginning, and swing to the anterior leaflet and grasp the anterior one, and having very good depth for the leaflet tissue in the device, and then close it. It's more controlled. You have better results as having more tissue in the clip, and you can deal with different anatomies, like having a big central gap. You can take a big clip. You have commissural problem. You can take the small clip, and this leads to improvement of the experience, improvement of the results as well.
Thank you. Thank you.
Okay, so let's go to the second part of the session today. I'm going to look at the same kind of topic, but just from the surgeon perspective, not the surgeon perspective, but I'm going to be digging a little bit on more details so that people will be aware of other aspects of the studies. And I think hopefully this will not change the message, but the message will I assure you the message will remain the same. So basically, the focus will be on the reshape and Matheron, but you can't talk about these without mentioning the study that Dr. Mohammed deliberately try not to address, the French study, which is I have to go through it, not because it's a negative study, but I think it also teaches us a good lesson. We're not going to spend much time. I think he mostly mentioned those, the most causes of MR. We have a primary or organic. And the primary, most likely, it's a surgical disease. If you have endocarditis, if you have a ruptured papillary muscle, if you have a rheumatic disease, if you have Barlow, Marfan, and fibroelastic deficiency, these are mostly class 1 indication for surgery. I think the topic is mostly for secondary, which is usually due to ischemic or cardiomyopathy or atrial fibrillation-induced remodeling and FAT enlargement. And as surgeons, and I think I would recommend also for people who are learners, I think knowing the classification of MR, it will be very helpful to tailor the treatment option. And I think even when I read or look at echoes, and we are teaching resident, it's very nice to have a nomenclature and definitions or terminology that when you tell me flail segment or prolapse segment, I know what does it mean in terms of this classification, and that means also an impact on the treatment options. If you tell me this is a type 2 Carpentier, I know it's an excessive leaflet motion, usually associated with a prolapse or a flail. If you tell me the leaflet motion is normal, so I always think along the type 1, which is annular dilatation or an endocarditis with healed perforation. If you tell me it's a type 3, I know it is tethered restricted. It could be from fused thickened cords or leaflet from rheumatic disease, or could be also restricted from ischemia and remodeling and displaced annulus and displaced papillary muscles. So I think it's knowing the types of MR classification based on the leaflet motion is very important in planning the treatment, and knowing the prognosis based on if I deal with excessive leaflet motion, this is the type of usually durable repair. If I'm dealing with type 3 or type 1, I'm always thinking toward replacement. So natural history, Dr. Mohammed mentioned it very clearly, and the impact of not addressing the MR, which is usually mortality of up to 90% and 5 years. It's almost, functional MR, AFib, it's like a cancer of the heart. I actually, we use the word, it's like the same, even worse than some of the cancer 5-year survival. If you leave it, MR begets MR, make it worse, leads to more annular dilatation, more LV dilatation, and more MR. So what is the purpose of our intervention, whether it's percutaneous or surgeon, is to try to interrupt that cycle. Because if you don't interrupt it, I know these days the medical therapy has done a good job, and I think more and more we see medical therapy has starting to play more significant roles in the management of these patients. But there are some people, I think, the mistakes that most people do is the looking at medical therapy and intervention as alternative. No, it is a supplementary. I think they complement each other. And I hope one of the early message I want the audience to come out with this is that device therapy or surgery, it's a complementary treatment to those cases, because sometimes medication alone does not do it. So remember, when we try to fix the MR, for secondary MR, we all think that it's just a coaptation gap that we need to bring together, then things will be fine, because we always celebrate the acute success when we look at TE in the operative field and we say, okay, we have a trace MR. But remember, the mitral regurgitation or the mitral valve is not a leaflet only. It is affected by at least 5 or 6 structures. If the atrium dilate on you, this can cause you a problem. If the ventricle keep dilating, it's a problem. If the leaflet is diseased, it's a problem. If papillary muscle get ischemic, is a problem. If the cord rupture, is a problem. So when you deal with mitral valve, the more you address those components, the more success, the more durable your repair will be. In MitraClip, you're only addressing one item. It is the coaptation. So you're approximating the edges, nothing done to the annulus. The annulus keep dilating, the ventricle keep dilating, the cords could be ruptured, could be elongated more, and the atrium can dilate as well. So you have to remember, and that's why Dr. Muhammad earlier talked about we don't have 10 and 7 and 8 years long-term outcomes in these, because a lot of these patients to start with were very high-risk patients. So to start putting a clip in a 50 years old with P2 prolapse, I think we're going to have a very difficult argument when you have a 20, 25 years of freedom from reoperation and operative mortality of less than 1% and freedom from reoperation over 95% with mitral valve repair. So let's just move on to the next problem. The next problem we have in those studies that's been studying the MitraClip is the grading of MR. The problem also between European studies and the American studies, both use different grading system. And up until now, yesterday I was listening to this PCR the discussion about the same topic. Experts from around the world are still struggling with grading of MR, how we grade MR. If the experts in the world are having difficulties grading the MR, then we will continue having difficulties tailoring the treatment and deciding which one will fit the treatment options. So I think if you look at the American, they're using effective orifice, regurgitant orifice area more than 0.4. On the other hand, you look at the European, it's 0.2. One uses the regurgitant volume of more than 60 ml per beat. The other one uses 30 to call it severe. So I think at the start, we are having trouble adhering to a unified way of classification of the degree of MR. So in surgery, we look at multiple factors. Like for me, if my anesthesiologist or the echo guys tells me you have a blunting of flow reversal in the pulmonary veins, or you have a flow reversal, this is the criteria: the vena contracta, the visual, the wall hugging. So we see you have to rely on so many multiple parameters. You cannot just stick to one number to say, oh, this is vena contracta 0.6, severe. Oh, this is regurgitant volume. And I think you have to also be experienced. And I think that's one thing one message is you need to make sure that you're actually measuring an actual MR and you're grading it correctly. So when we looked at the guidelines, again, I think recently in 2023, between the American and the European, they decided to have together to look at the both and try to come up with similar guidelines. But if you look at them more or less, I think they're the same. I think none of them, when it comes to secondary MR, there's no class 1. So for a patient who's undergoing any kind of procedure, CABG or AVR, and you have ischemic or is having functional MR, it's being given a class 2A. If the patient is he's inoperable, I think the TEERs will be class 2A. For patient who is severe secondary MR, irrespective, related to LV dysfunction, despite the optimal therapy, surgery could be offered as a class 2B. And patient with severe secondary MR from annular dilatation, normal EF, symptomatic despite medical therapy, I would consider mitral valve. This is the case that was presented by our colleague earlier when she mentioned severe MR, normal EF. So it is a class 2B. But again, importance also in the guidelines, heart team discussion to discuss the treatment option is a class 1 recommendation. So it has to be done. Unfortunately, in our center, we don't do it. The TEER team works independently. They only call us when the leaflet detached or when the patient echo criteria is not good, and then you ask us to be involved. But there's never like a TAVR or valve clinic where we surgeon, cardiologist see the patient together, review the CT and echo. But the mitral team, I think we're still behind in terms of implementation of heart team approach. So this is just, I don't want to spend much time, but I think for the sake of time, they're trying to show you the difference between European and American. So if the guideline, if the grading is, we're not agreeing upon one way of grading. If the guideline is slightly different, like here for patient who's going for surgery, class 1 for European, the American saying class 2A. Again, for TEERs, if you have high risk ineligible or inoperable, you have an EF between 20 and 50, but with left ventricle end systolic diameter less than 50 and systolic pressure less than 70, then you go for TEERs. Otherwise, you don't. If you have a supersystemic pulmonary hypertension and you have a ventricle that is the size of my head, don't send them for TEERs because it's going to fail and you're going to spend $50,000 or $40,000 for no reason. You probably start talking to the transplant or assist device team to say, hey, this is beyond, and we'll get to that point when we have to be exact what type of patient that we're going to send for TEERs. Some of this information might be old, but I think for people who asked earlier about the criteria when you are sending patient for echo to say whether this is a fit or eligible for mitral clip, I think there are some nomenclatures and information that would need to be reported beside just saying LV, mitral, degree of MR, BISA, vena contracta. I think people looking at the mitral valve area, and in my days when I used to do them, I think anybody less than 4 centimeters square will be turned down for MitraClip. Looking at the coaptation length, flail gap, flail width, anything less than 15 is ideal. If it is the flail width is too wide, means you have to apply many clips, and that might end up with some significant residual MS, mitral stenosis, if you end up doing a lot of clips, if the flail gap is flail width is wide. So what are the evidence behind using the TEERs? I think we all know the trials, but I'll go over them in a very different way than usual so that we know the differences between the people involved in the trials. So we have COAPT and Mitra. COAPT is American, I think funded by the Abbott. The Mitra is funded by the Ministry of, I think, French something. The Reshape trial is the newest one, which is published in 2024. All of them addressing the concept of TEERs versus medical therapy. Okay. So we have the COAPT. And COAPT population, I think, was probably the largest of all the trials. I think it's over 600 patients. They were all symptomatic despite medical therapy. Effective regurgitant orifice area was more than 0.3 and regurgitant volume more than 45 mil, and EF was between 20 and 50. And the primary outcome was heart failure hospitalization at 2 years. The results, we saw that there's clearly in favor of the clip. So that was 28% in the device versus 43%, and the heart failure hospitalization was 35 versus 68. If you look at the Mitra, the French study, again, they used a different definitions or inclusion criteria. They used the effective regurgitant orifice area more than 0.2. The regurgitant volume was more than 30 mil, and EF is more or less the same. Again, when they looked at 1 year outcome, there was no much difference in terms of the heart failure hospitalization and death. So people at that time say, and I think I remember from I think Mahmoud could correct me later on, I think they were like published probably a month or two apart. And if one side, cardiologist says, oh, COAPT is positive. The other guys who are non-MitraClip operators, but we have a trial that says no. So there has been that discussion about, oh, you guys are always just following the positive trials. But I think the key is you have to look at the details of what type of patient were involved in this. We will get to that shortly. So if you look at the two trials, in fact, enrolled different patients. And that's why we probably end up with the different results. So if you look at the mean LV in diastolic volume for the COAPT was 192 mil. In Mitra was 252. And we've had only 16% of patients in the Mitra with a mitral valve regurgitation with effective orifice area more than 0.4, only 16%. And in the COAPT, we have 41%. That tells me that Mitra French has involved or enrolled patient with much more advanced cardiomyopathy, with much more dilated ventricles, but a lesser degree of MR. And on the other hand, COAPT involved patient probably with severe MR and still a smaller ventricle that potentially would benefit from. So at the Mitra, I think they were much sicker patient and much dilated ventricles. And we look at this result at 1 year, moderate or worse MR. In COAPT, we only have 5 versus Mitra were 17. And again, there's also the differences. This is here just one thing I would like to highlight. I think the Mitra, there was with regard to the patient has to have hospitalization with heart failure within the year before, and the other trial was not required. Prior hospitalization, at least one heart failure hospitalization within 12 months. Here with the COAPT was 50-50. I think either hospitalization or your BNB more than a certain cutoff. So clearly the Mitra patient were much more sicker, dilated LV, but with a lesser degree of MR. Again, you look at the bigger ventricle, bigger volume. In terms of the adherence to the, I think, beta blocker, ACE inhibitor, and diuretics, more or less, probably they were balanced. So again, if we look at despite that we have two different studies addressing same questions, if you look at the Mitra at 1 year death and hospitalization, 55% versus 34, drastically different because the population are different. So for medical therapy alone, again, they're different. But again, if you look at the intervention group where they did the clip, 34 versus 55, and when you look at the 1 year deaths, again, 19 versus 24, and then medical group 23 versus 22. So we're dealing with two different population here. And that has raised the very important concept. I think studies following the publication of these studies, they come up with this concept called proportionate and disproportionate MR. So which patient would benefit from intervention is whether disproportionate like the COAPT. COAPT has a smaller ventricle, much more severe MR. The Mitra has much bigger ventricle, so they have a proportionate MR. So they have a bigger ventricle. So you look at here, COAPT falls into the disproportionately severe MR versus the Mitra into this category. So the bigger the ventricle, the more proportionate the MR. So the people who likely benefit from MitraClip is the one with disproportionate severe MR. Smaller LV, more severe MR. So the concept of proportionateness of functional MR is referred to the amount of functional mitral regurgitation present in relation to the amount of left ventricular remodeling and functional impairment in a given patient. Patient enrolled in the Mitra valve, Mitra FR study had an average of approximately 30% higher LV in diastolic volume and 25% lower effective regurgitant orifice areas. Larger ventricle with lesser severe MR than patient enrolled in the COAPT trial. So just bear in mind this important principle. We come down to the ReShape trial. I think this is I think more than the French, 505 patients with moderate to severe secondary MR. And despite medical therapy, they all have to fail medical therapy to be enrolled. Again, definitions, they use a lower definition of MR. They define severe MR is effective regurgitational orifice more than 0.2. Regurgitated volume is only more than 30. EF is more or less the same. Again, TEERS versus medical therapy. Primary outcome was heart failure, hospitalization, or CV death over 24 months. They also use some sort of quality of life, the Kansas City questionnaire or something. So mean age of 70, 78% were male, 65% were ischemic cardiomyopathy, 35% were non-ischemic. EF, more or less the same as the other trials, around mean of 32. Again, they introduced another dilemma. The LV end-diastolic volume is 200. We had 192, 200 plus, now 200. And 55% of the patient had moderate MR. Again, it's not the same patients. And when they look at the outcome, procedure success, MR moderate or less at 12 months, 90. If you are 50% of your patient had MR, you include them in your outcome and you're calling it 90. Is that a success? I'm not sure, because in surgery, if we leave more than trace, we're going back on pump and we're trying to do something else. And the cardiology will be screaming and yelling, say, wow, it's a 1+, it's not good repair, blah, blah. But here, moderate MR or less at 12 months is 90 is okay. So, and recall that the trial recruited patient with moderate or severe MR. So having moderate MR at 12 months was kind of funny here. Again, the study showed, as Dr. Mohammed showed, that the device is better, have a relative risk reduction of 36% at 2 years for composite of hospitalization, heart failure, and death from cardiovascular cause. Same thing for hospitalization for heart failure. If we put all three together, we can see the difference between both. So if I'm a guy who comes in here trying to come up with what is the evidence to implement? So one study tells me COAPT reduces heart failure, hospitalization, and death. Mitra, no difference. ReShape, reduce heart failure and death, but driven mainly by heart failure, no difference in death. I would be confused, knowing the heterogeneity of patient involved, the different cutoff of LV diastolic volume and the EF and the regurgitant volume, and then I'm just gonna say, which one I should use? Should I just stick to the COAPT patient? What if I come up with a patient with the criteria of Mitra? So I think you need to know the details of each trials and the breakdown of exclusion criteria and the echo features and EF and regurgitant volume to say, okay, this patient would benefit. And I think the concept of disproportion and proportion MR was very important. So if you look at here, look at the mean LV, like the EF was similar. The LV in diastolic volume, I have mean of 192. Then Mitra is a bigger ventricle, more advanced, then slightly smaller and ReShape. If you look at the effective orifice area that's used as a cutoff, in COAPT is 0.41 centimeter square, in Mitra is 0.31, and this is 0.25. So we have 3 different degrees of MR, in my opinion, and they all call them severe, just because they're each relied on a different guidelines, and that's what's confusing the situation. The proportion of people with more than 0.4, which is definition of severe MR by the American, is 41% in COAPT, only 16 in the French, only 14 in the ReShape. Again, the same. Now it comes to Mathuron. Hopefully I won't be taking too much time. Dr. Mohammed mentioned this, but this is a randomized control trial. Dr. Mohammed forgot to mention that this is a difficult trial to recruit. It took them almost 10 years to recruit and finish. And I'll say it up front. No, the surgeon, I don't understand how this is being accepted. If the surgeon knows from the CTSNet trial that mitral annuloplasty ring had failure at 2 years up to 60%, why allowing annuloplasty as a method of repair? We know replacement with chordal sparing will do a much better job. Up to 70% of patients enrolled in the surgical arm had mitral valve repair. Repair means mostly annuloplasty ring or doing some, papillary muscle thing or some cords, but not the classic quadrangular section, triangular section, or the classic degenerative techniques. But allowing such an inferior techniques to be done at the discretion of the surgeon actually hurt the surgical arm, which is, to me, was a surprise. Why this was not a replacement versus TEERs? Because if you allow repair, by definition, you're putting yourself at a big disadvantage. But this is one thing at the inclusion criteria. So they used, again, effective orifice area more than 0.2. This is mostly European guidelines. Regurgitation fraction more than 50, vena contracta more than 5. So by definition, they were calling it severe secondary MR. Ejection fraction has to be more than 20%, and patient had at least 2 admissions within the last year. Comparing surgical mitral. So in the surgical group, ablation was allowed, tricuspid valve intervention was allowed, and not the revascularization. And the primary outcome was composite of death, heart failure, mitral valve intervention, ventricular assist devices, and stroke. Again, the same thing. You can't compare one intervention where you're only doing one thing and you go. Same thing happened in TAVI. In TAVI, when you look at patient in TAVI, 25% underwent another procedure in addition to the aortic valve replacement. Here, if I'm doing a tricuspid valve replacement or ring, or I'm doing ablation, I'm going to make the operation much more complex, much more longer, more risk of bleeding, more risk of pacemaker, more risk of adverse events. So it wasn't clearly a purely head-to-head. Baseline characteristics, 70 years old, 60% male, and median ERO score was 3. So they were reasonable, low-risk patient. One thing is important here is another variable been added. LV in diastolic volume is 160 and much better EF. So now we're testing patient is much healthier patient. So we have to look at the patient criteria. We started 200, 250, 190. Now we're down to 160. So they are, by definition, a much healthier. So that's why I think patient could be randomized to surgery. So EF is 43%. The mechanism of MR, 53% were annular dilatation, 47% were ventricular tethering. The mean effective regurgitant orifice area was 0.2, and the study was 72% were repair and 28% replacement. I just looked at this and said, wow, we're not going to expect a good result, and there will be a lot of recurrent MR. And I'm surprised, actually, to see at 1 year, the moderate or worse MR is 1%. In the CTS net at 1 year was about 20-30% at the arm where there's a mitral ring, and at 2 years I think was over 50%. But it must have been a very good mitral repair, and they've used a lot of techniques to do. But again, I would expect if you replace the mitral valve with chordal sparing, I think they used artificial cords, closure cleft, ablation, and so anyways, so the moderate MR and the TEERs was about 8.9 and surgery was 1.5. There was no difference. And that was exactly what Dr. Mohammed showed earlier. So in patient with severe secondary MR, TEERs was, this is the conclusion of the study, TEERs was non-inferior to mitral valve surgery with respect to composite primary outcome of death, heart failure, mitral intervention, and LVAD and stroke at 2 years. So the concern I highlighted earlier that the percentage of people who have repair is very high, almost 2/3 of patients, which we know repair in the surgical arm associated with very high recurrence of failure and recurrent MR. 51% of patients had AFib, but only 19% underwent ablation. So maybe a lot of patients had significant AFib and not addressed, and that might be also could have an impact on the outcome. We only have 1 year outcome. I think we should be following these patients, and hopefully we will see 3 and 5 years outcome. We shouldn't be celebrating and changing guidelines based on 1 year outcome and declaring non-inferiority early on. Would you offer mitral valve surgery to a patient enrolled in this trial? I think the MR is moderate, mostly to my eye or my definition, and EF is preserved. I mean, if EF of 43%, I would definitely, if patient sent to me with moderate to severe MR, functional, EF is over 40, I would do chordal sparing valve replacement. I think that operation is a very low risk. I don't think it's a 10% mortality. But I do believe these were very low risk patients and they will do better with replacement. In conclusion, secondary MR is a disease of the ventricle and atrium and valve and not just a leaflet. I think heart team should be discussing all these patients to come up with how we can fix the MR. And because fixing the MR will benefit a selected patient, we need to know in whom we could do it, how we can fix it, whether with TEERs, with replace, with repair. And we need to have a consistent definition of a degree of MR. And when we know it's moderate and severe, I think we need to speak the same language. And consistent definitions of the procedural success. The result of, this is probably the most important take-home message, the result of the 2 trials, the French and the COAPT, I would interpret them as a complementary rather than contradictory, and that's an important message. One helped us to know which one we should be treating. The other ones helped us to know which one we should avoid. I cannot overemphasize the importance of guideline-directed medical therapy. I think it should be implemented early on, before and after. And in some patients, which is interesting, in one of the discussions I attended, the early introduction of MitraClip, if it was successful in the right selection of patient, it would allow you actually to titrate your medication more. So if you, before the mitral clip, for example, your patient is a bit hypotensive or you can't do much to titrate his meds, I think after you do the MitraClip, maybe this is a question to the people who deal with these patients, do you notice that they are actually, you'll be able to introduce more medical therapy and you titrate the medication more. TEER should be offered to patients with severe functional MR, the criteria of the COAPT. Patient with advanced cardiomyopathy with class 4 symptoms or RV failure, severe TR, marked LV dilatation, severe reduction in the EF, they're not good candidates for TEERs. Patient with disproportionate functional MR, patient like the one in COAPT, were more likely to derive benefit from TEERs rather than those with proportionate MR. Thank you.
Nice, Dr. Adel.
I would just stop sharing here. Let me just leave it to the slide. Last one.
We have a question from Dr. Mahmoud Traina.
Mahmoud, go ahead.
Great talk, Adel. You actually surprised how fair you were in general. One of the things that I will mention specifically about the MitraFR trial compared to the other 2, because you had that nice slide, if you go back to the proportion disproportionate. And so when we were describing proportionate, that was an argument we were using a lot before Reshape 2. But if you go back, you had a slide with Reshape 2 also plotted. After Reshape 2, I think you added Reshape 2. Go forward. You had where you had on the plot of the ventricles. Keep going. I think this one. So if you see this trial, so Reshape 2 is also proportionate, but was positive. So why was MitraFR negative and it was proportionate and COAPT was disproportionate? Now Reshape 2 was less positive than COAPT, but the difference is COAPT and Reshape HF2 had a very strict policy about guideline medical therapy. So when you actually read the MitraFR and you read the supplements, most of the patients were on minimal therapy at the time of enrollment to the clips, and they actually had their therapy increased. So if you look at the medical therapy arm of MitraFR, they symptomatically improved significantly. So they changed functional class up to 1 to 2 in many patients. And it just goes back to the main point to me is one of the main differences between those two trials and the MitraFR trial is that it was an interventionalist run trial. So it was run by the Ministry of France, but it was an interventionalist run trial. So they saw MR, they clipped MR, rather than they sent it to a heart failure person to optimize, get them on good medical therapy, confirm that it persisted, and then clipped it. And I think that's a very important principle that these trials pointed out to us in terms of the therapy. And then I think you had another point about the Matterhorn in terms of the replacement versus the repair. I think this was a trial of isolated MR. So I think, many of these patients are not good surgical candidates. So they're generally not going to be candidates for therapy. And now the definition of severe MR is 0.2. I mean, in functional MR, EROA over 0.2 is 3+. And when we start passing 0.3, it goes to 4+. And those are the patients that we're going to be targeting in the therapies. And I think any MR over 0.2, their patient, if they're optimized, is going to have a benefit from intervening on the mitral
do you
valve.
rely on a single number?
No, of course. I mean, of course, like everything in medicine,
Yeah.
it's just like in TAVR, there's no single valve area, there's no single gradient number, there's no single. But in general, if we had the best quantification, if the MR is eccentric and if the EROA is not well calculated, there's a million things. But we have benefit even from 3+. So they don't have to be 4+. Huge rip-roaring MR. Even at 3+, as we've shown from Reshape, probably the COAPT was more closer to the 4+ type patients, whereas the Reshape is more of the 3+ type patients with the 0.2, I think 5 was the mean
Moderate
EROA.
to severe. I would call it moderate to severe, right?
Yeah, what's 3+? That's what people usually call it moderate to severe, and then 4+ is severe. So even if you're in the moderate to severe range, you get a benefit from therapy. Again, assuming that you've done everything else to try to fix the MR medically, and it didn't work.
Yeah. So let's see who is Dr. Mohammed. Do you have any comment before we open the floor?
I have a question.
I think you can give the comment as well. I have Osama Bisht, a very good experienced operator in the field of edge-to-edge repair. I think he has a comment as well. We can give him the
go
chance.
ahead.
أسامة اتفضل.
السلام عليكم دكتور محمد، اهلا بحضرتك. دكتور عادل، فرصه سعيده جدا تعرفت حضرتك.
مرحبتين.
بالنسبه للهيتروجينيتي بتاعت موضوع الترايلز ديت، يعني فيري انترستنج توبيك، لان هو في كذا فاكتور. اول فاكتور هو الايجكشن فراكشن كماركر. هو الايجكشن فراكشن ده اخر حاجه بتبقى بتسوق في المايترال ريجيرش. الاول حاجه بيبدا سب كلينيكال ال في ديسفانكشن، بيبدا من الاول في السترين او في الام ار اي، وبعد كده الفيري ليت ستيج بيبان الايجكشن فراكشن الوحش. ومعنى كده ان احنا المريض اللي هو لو وصل ايجكشن فراكشن 20% هو دامج فنتريكل. اوكي، فهو يعني سكارد فنتريكل. لو طلع يعني انا ما شفتوش ولا مره في حياتي، بس اكيد انا شفت في الجراحه لما يبقى سكارد فنتريكل، هو مش علاجه ان انت تحط له مايترا كليب ولا تحط له فالف، هو علاجه ان انت تحط له اسيست ديفايس. فدي اول نقطه الايجكشن فراكشن. نقطه بالنسبه للريجريتيشن فوليوم والايروا والكلام دوت، هو الميترال فالف ديزيز هو دايناميك ديزيز. It is not a stationary condition. هو الميترال كتير جدا مش مرضى اول لما يبدا يعمل اكسرسايز تلاقي سيفير ام ار الليفت اتريال بريشر زاد. فهو طبعا احنا الجولد ستاندرد must be changed for the diagnosis of severe mitral regurgitation to stress echocardiography not static echocardiography. لان جزء كبير من المرضى جدا بيبان ان هو الايرو نول كوما اينز 1 من 10 او 2 من 10 هو اكشولي سيفير مايترال ريجيرش. لما بيبدا يعمل اكسرسايز بتلاقي سيفير بالمونري هايبرتنشن معاه وسيفير ال في ديسفانكشن والسترين او السب كلينيكال بارامتر بتاعت ال في ديسفانكشن. We should do a better job in detecting mitral regurgitation. ادي اول نقطه بالنسبه للترايل ديزاينز. وهو احنا شايفين مور اور ليس باترن بيتكرر، ان هو السيفير ام ار وذ جود فنتريكل هو المريض اكتر مريض بيستفيد من المورتاليتي. المريض اللي هو مودريت ام ار او ام ار مش قوي قوي مع باد فنتريكل بيستفيد من الهوسبيتاليزيشن. وثالث حاجه المريض اللي هو بور فنتريكل ليس ام ار ده ما بيستفيدش اصلا خالص. هو ده باترن احنا شايفينه بيتكرر في كل ترايل.
معلش أنا عندي
ادي
سؤال
اول
ليك
بوينت.
لحضرتك، معلش.
اتفضل.
أنا كنت عايز أسأله بدري. There is a subset of patient. Which patient that you would recommend to do a stress echo to delineate the degree of MR؟ لأن زي ما قلت إن أنا واحدة من المشاكل اللي هي تحديد ال quantification of MR. مرات تشوف مريض يعني الام ار نعرفوه يعتمد على البلاد بريشر والفوليوم و يعني انا بعمل ام ار اسسمنت والبريشر 85 systolic is different than with the pressure is 130. هل هو
تماما.
بس انا
المريض اللي هو عنده كاردياك
how often
دامج
you do
اللي
it؟
عنده very often we do it very often. والمريض اللي عنده ماركرز اوف كاردياك دامج. يعني ايه ماركرز اوف كاردياك دامج؟ يعني مثلا عنده
cardiac
فور
MRI
اكسرسايز
يعني؟
كاباسيتي. لا مش بس ام ار اي، في حاجات كتيره تخليك تشك ان المريض دوت عنده سب كلينيكال ال في ديسفانكشن وسيفير ام ار ومش باين. مثلا لما المريض يكون عنده unexplained pulmonary hypertension او unexplained right ventricular dysfunction، دي معنى كده ان في باثولوجي ما عامل افكشن للرايت سيستم. اوكي.
لا.
لما يبقى المريض مثلا عنده بور اكسرسايز كاباسيتي، لو تعملوا سبيرو ارجومتري اكسرسايز تيست تلاقي فيري بور اكسرسايز تيست ريزلت، والمريض مثلا انجكشن فراكشر 45%. المفروض ما يبقاش كده. فدول المرضى اللي هم بيبقى عندهم ام ار 2 او 2 بلس، احنا بنكتب 2 بلس 3 بلس 4 بلس 2 بلس. الجروب دي لو هو عنده كلينيكال ماركرز او يعني كلينيكال سسبشن اوف كاردياك دامج، ده بعمله ستريسنج، ببعته يعمل ستريسنج. وطبعا لازم اكسبيرينس اوبريتور اللي يعمله.
Good.
تمام.
I had a note for you, Dr. Osama. You have to do the exercise when you are making echo.
احنا بنعمله بنعمله يا اما بالارجوميتر يا اما
Maneuver test,
بالهاند.
maneuver test. You have to make a maneuver test as you as Valsalva as do you know it, and the historic dysfunction. It will clear the good assessment for mitral regurg.
طبعا. بس هم دول الجروب اللي هم يعني should be the focus of the trials، يعني مش فقط اللي هو الايجيكشن فراكشن 20% وام ار 2. ادي اول نقطه. ثاني نقطه في الترايل ديزاين نفسها اللي احنا بنتكلم فيها، احنا بنتكلم في الاند بوينت. الاند بوينت انا رايي الشخصي ان هوسبيتاليزيشن او ري هوسبيتاليزيشن والام ار 1 ولا 2 shouldn't be the end point. ليه؟ لان هو مريض بور ليفت فينتريكل اصلا، هو عنده بور ليفت فينتريكل، ما هيبقى ري هوسبيتالايزد. واخد بال حضرتك؟ فهو يعني it is not realistic ان انت تتارجت ان المريض يبقى not really hospitalized. هو ejection fraction is 25%. he will be hospitalized. اوكي. ادي اول نقطه. ثاني نقطه، احنا we are not doing cosmesis for the valve. we have what's most important is the function of the patient as a whole organism. البيشنت اكسرسايز كاباسيتي بتاعته بتتحسن، السيمتومز بتاعته بتتحسن، ما يبقاش عنده ديسنيا every day. دي كل الحاجات دي important marker. مش بس الايكو هو يعني الام ار او اينز ولا 2 هو دي مش يعني لو الام ار 2 بس المريض كلينيكالي ماتش بيتر. خلاص.
عايز اسال
احنا
عايز اسال معلش دكتور، عايز اسال لمحمود محمد بس. يعني بس I'd like to ask a question اللي هو حيكون ممكن مش نقول خاتمة، لكن what are the patients or the criteria, clinical or echo or any other parameters that you would say this is not for MitraClip? Echo criteria, patient criteria, LV, and presentation. If you guys can give us 1, 2, 3, 4 point, say this is not for a clip. نبدأ بمحمود وبعدين محمد. Which one you would not clip?
So there's multiple people that you wouldn't, and then there's very few absolutes. So everything is to a degree relative once you have the indication. But the anatomy is the main thing, is when you have degrees of stenosis of the valve or calcifications on the valve. on the leaflets, and when your likelihood of having mitral stenosis is high. So valve area, you look at it, you look at also the anatomy, clefts across it where that you open up, and so there's different anatomic criteria when you look at the TEE that you say this patient is less likely to benefit and more likely to develop stenosis. That being said, these are all relative. So when you have a patient coming in and out of the hospital, very old and frail and not a surgical candidate, and really not much else to offer, we do some of these cases, because even if you know that going in that you're not going to get down to 1+, you probably end up with 2+ MR, but they can benefit. But the anatomy is probably the most important part. The second group of patients that's a challenge, and that's why most of the discussion actually for us in our center, we actually meet with the heart failure transplant and with their surgeon, and when we discuss these cases, is because the EFs, I think Harari asked a question as well about this. So what do you do with those EFs of 15, 20%? And, he sometimes sends some of these patients, and it becomes a debate. Should we consider them for VAD transplant, or should we consider clip? And sometimes in those settings, we opt to still clip them if their index is not less than 1 and their hemodynamics are not too horrible, to try to delay VAD transplant. So it becomes a debate, and sometimes it becomes a win, and you're able to delay them for a few years and they don't need advanced therapies, and sometimes you clip them and they still need a VAD or transplant 6 months. But I would say those are the two categories: is anatomy that's calcified, high risk, and then the second group is those very advanced cases where you have to consider which way you go.
Mahmoud, along the anatomy, I remember, do you guys, when the jet is a multiple, especially the commissural jets, I think the clip navigation through the commissures with all the cordae and entanglement, it's much more challenging. Is this technically, if you see a jet that is commissural or multiple jets, are these one of the criteria where you abandon?
Yeah, but so usually those are commissurals are usually, if you have commissural MR, it's usually a leaflet problem. It's not usually a functional problem, usually. So usually if it's functional, it's usually, it can be very broad, but it's usually P2 related. So when you start to get commissural, there's tears in the commissures. Again, it's the same thing. It's not absolute. So you can do a P3 chordal flail and the thing, if the patient's not a good surgical candidate or whatever reason, it's just much more risky, and you get worried about getting into cords as you start getting into the commissures. Yeah. So that's another factor in the anatomy. If the posterior leaflet is very short and retracted, so less than 5 millimeters, then it's not a candidate for clip. But again, most functional cases, those are not a problem. So those are generally when it's a mixed picture, is when you start to have these anatomic issues, is where you get. The other point is when the gap is big, like those atrial functional MRs that are in those AFib patients. They can sometimes have very big gaps where you can't actually bring it together. And those are the things on the anatomy. But one other thing I just wanted to mention is one of the problems actually, and this was, probably you guys need to do another session on echo assessment, because probably the main issue that I see in patients that are late referred is that everyone underestimates the MR until finally the patient keeps coming back and somebody looks at it closer and it's actually severe, and probably was severe all along. So echo assessment and detailed echo assessment is probably one of the major issues we have across the region, and in terms of quality assessment of MR.
That is, I think, a very important point, Mahmoud. I think we'll probably ask one of the, maybe Ayman or one of the echo people, to maybe Osama Al-Ghusbi. I think this is a very important topic in general, not only for MR, not for the functional, is how to properly assess MR. Dr. Muhammad, can you answer along the same?
I add another group. I totally agree with the two groups that Dr. Trina mentioned. The first group, the patient who is not suitable anatomically, like stenosis, like cleft, like as Dr. Mahmoud Trina already mentioned. Regarding the group that you have mentioned, Dr. Adil, the group with multiple jets, I think you mean Barlow patients with this with this anatomy. Even with this, if the patient is not operable, I think we have a solution. You can target the most relevant, and I had done some patients like this. You can target the most relevant jets. Even you shouldn't have to put the two clips beside each other. You can put them on the extremes of the valve, where the extreme or the biggest jet are coming out from through the coaptation line. This can be done with some tricks with this difficult anatomy. Another group which is very important that I'm not going to touch or not deal with, the patient with who are asymptomatic even with severe mitral regurgitation and have normal NT-proBNP. We depend too much on NT-proBNP for the evaluation of the patient, if the symptoms are coming from the heart really or not. And the patients who are symptomatic and normal NT-proBNP, you have to search for another reason for dyspnea, maybe pulmonary disease, maybe obesity, maybe any other cause. That's why patients who are asymptomatic and normal with normal NT-proBNP, I'll not touch them as well, in addition to the two groups that Dr. Mahmoud Tarina mentioned.
How about the patient with severe pulmonary hypertension, RV dysfunction?
RV dysfunction, pulmonary hypertension?
Yes, severe pulmonary hypertension. If you have a patient with severe MR, functional, and a PI pressure of 78 and moderate RV dysfunction, would you clip him?
If the patient is symptomatic, and NT-proBNP is high, I'd clip him, yes.
Yeah, that's a problem for tricuspid, Adil, not for
No, there's no TR.
But not with the mitral, exactly.
Yeah, I'm
exactly.
saying that those are important problems in the tricuspid space, not in the mitral space. For us, those are in the interventional world, those are not a problem.
So for the left-sided mitral clipping, even
those
systemic, super-systemic mitral hypertension, like pulmonary
this is not a problem.
you guys take them and to take care of them, no problem.
The only issue on those patients, if their cardiac index is very low, and that's the reason, that's part of the problem, why their pumps have bad pulmonary hypertension. They have, then you start to, are they that group that I was talking about? Are they too advanced?
Yeah.
And should you be considering them if you have those options for advanced therapies, VAD, transplant?
Yeah. Okay. Let's see if there's any questions from the audience.
I have note for you, Dr. Adil. You have to focus on durability of mitral valve replacement.
Is this a
in your
question
lecture
or a comment?
No, comment for you.
We have the durability. Durability of the mitral valve replacement is very well known, been studied for many years.
Very well. Durability is more than that here.
Can you repeat the question again?
You have to focus on durability of mitral valve replacement.
We know the durability of the mitral valve replacement.
Yeah, in your session, you don't mention.
Well, mitral valve replacement is as a procedure is not new. It's not new. Like we just introduced it like a few years ago. It's been there for different indication, whether it's mechanical or usually in this world. I think we're dealing with a tissue valve mostly, because I think we're not thinking about 20-year survival. The dilemma and the question is probably I'm going to ask, if you have a 48 years old patient with EF of 45% with a functional MR, this is the challenge become. I think most of the study we've seen mean age was 70 or above. I think a lot of the study were older. The challenge become when the patient is 48, severe functional MR, AFib, class 2 symptoms. Would you clip him at that age?
So we see probably relatively more of these kind of patients, and it does become a decision discussion, where they're potentially surgical candidates. What I would say is that patient with that, if they have that degree of myopathy, doesn't have a normal life expectancy off the bat. So you're already dealing with a patient that's not going to be living to 70 and 80 if they already have a cardiomyopathy that's led them to have severe MR. So it becomes a debate. In our center, what we've opted for is if they are a good clip candidate, we'll clip them because it doesn't take surgery off the table. because they, like as you mentioned, they would probably opt for a replacement procedure rather than a repair procedure. And generally, that's what we've been doing. I don't know if that's the right answer, but that's kind of been our practice. And I don't know if there's any clear answer from the data.
I'd claim him as well. I think symptomatic relief is also a target for such group of patients. And we don't have only to work on the prognosis, but if you have your patient for 2 or 3 years symptom free or with less symptoms as doing simple things, less rehospitalization, I think this should be an aim as well.
Adil, would you argue for surgery for that patient?
You know
I
what,
don't think.
we get these patients and they like I get a 47 years old. He has severe TR, AFib, and severe MR, good LV. Like I would say 50, 45, not normal LV. She was Vietnamese, whatever, but she, you know what, we replaced the mitral, we replaced the tricuspid, we did the ablation, and you know what, she comes to the clinic, she's on 20%, 20 Lasix, she was like cannot walk, have a block before, but she also had a moderate to severe pulmonary hypertension. I mean, younger patient, I mean, our group would be very hesitant to do structural intervention for some reason. I think.
Yeah, if you have maybe because you guys don't see them as much in this region, we see more, but yeah, I think it's different if they have other valve disease, other indications for surgery that you could potentially benefit from, becomes different. Because then if you're talking about, I don't know if Muhammad does simultaneous mitral tricuspid. It's not our practice to do it, so we don't do simultaneous. So even in those cases, like that patient, you're talking about, you took care of 4 percutaneous procedures in one. You did the mitral tricuspid, you did a AFib ablation, and you probably also cut out the appendage. So you did 4. Those would be 4 procedures for us in the cardiology world.
Yeah.
So I think, yeah, if somebody's like that and has other indications, a lot of TR, we will probably operate on them. But if it's just isolated mitral, we've been mostly clipping these
I think,
patients.
Mahmoud, when I look at the guidelines, the problem, like if you look at the guidelines for TAVR, I think the American and European did a good job at using the age. Here is 65, here is 75, whatever. In mitral, it's all about surgical prohibitive risk. If it is the surgical, they don't talk much about age. But I think age, because we will see a lot of those AFib-induced cardiomyopathy in a younger patient that are coming with big atria, big annulus, MR. And I think that has been also the same discussion, same question being asked from the EP guys about 40 years old comes in with AFib. Would you occlude the appendage percutaneously or thoracoscopically? Because the appendage is good for them for their exercise capacity. You don't have any proof that occluding the appendage in that age group will. So there was argument against occluding the appendage in younger patient because the appendage plays a role in compliance of the atria and whatever. So I'm asking the same question for the clip.
Because the problem is the mitral valve is much more complex. Aortic stenosis is one disease. It's an easy disease. It's, everyone knows what it is. But mitral, even if you look at the data, even if you look at the initial Everest trial, which was the first MitraClip trial, that includes some degenerative and some functional. And then we have patients that are pure degenerative, and then we have pure functional, and then we have a little bit of both. And then you have patients that have ischemic MR and functional. Some of it's ischemic and some of it's AFib related and some of it's due to dilated cardiomyopathy. So you're mixing a lot of, it's a very, there's a lot of phenotypes of MR. So even in the secondary, which we're just talking about, there's the atrial functional MR, which is from the AFib patient. There's the dilated cardiomyopathy MR. There's the ischemic MR with triple vessel disease. There's ischemic MR post-CABG. There's ischemic MR
the ones that I don't hesitate is post-CABG, and if the moderate MR becomes severe, please do not even call. Just go ahead. Go ahead.
So it's a very heterogeneous group, and I think that's why it'll hard to be a guideline for all these different groups of patients, and I think that's just needs good discussion and what the surgeon can offer, what the interventionist can offer for each patient, and kind of come up with local kind of protocols for these. But I don't think it's going to be an easy to have one
And
answer fits all for these
And that's
patients.
what brings me, Mahmoud, to the point of the importance of large database or large registry. Like, I think I didn't want to share it, but I think there is maybe I think a Swedish or more than 4,000 patient. Because I think to me, when there is this heterogeneity and the patient included and outcome assessment and all this point that we discussed, when you have a large registry of thousands of patients, that might be because it's more reflective to the daily practice rather than in a very sub-selected, very well, core lab, looking at echo and criteria for definition of outcomes. But I think when we have such registries, I think it might be actually helpful to give us a message, especially most registry will give you not only 30 days or 1 year, sometimes you can look at 5 and 3 and 4 and whatever years. So I think there is a recent publication by a registry. I think it wasn't in favor of the clip, looked like the clip and maybe because the medical therapy is up to date. I'm not sure if that has an impact. The clip did not look very good.
Yeah, and it's a lot in real world, and Muhammad will probably say the same thing. In real world, there's a lot of cases that you get for clip or that you're stuck with. That you don't want to clip. I mean, it's not something that you want to do. The beauty of clip is that it's extremely low risk when somebody knows what they're doing. It's extremely low risk. But, you get these cases that are in and out of the hospital. They have the mitral annular calcification, short leaflet. And they ask, and then, the heart failure is nothing else we can do. Can we do something to reduce the MR? And you're not excited about going into it because you're not going to get a perfect result versus somebody who has a very nice dilated cardiomyopathy, nice long leaflets. Going in, you're going to get a great result. So I think there's in real world, there's a lot of cases that would have been turned down that people are doing that would be turned down for some of these, both the reshape and all these trials. Anatomically, they were very strict on anatomy criteria.
أسامة بشاع من اللي عنده كومنت من اللي عنده أسامة
تمام. هو طبعا كلام رائع جدا وممتاز جدا، بس انا ليه كومنت بسيط. يعني هو مثلا ماترهورن ترايل كانت بدات 2014 كان في already surgeon had 30 years of experience in mitral repair and the cardiologist had maybe done 2 cases. Okay. احنا بنقارن treatment which is already very mature في very experienced surgeons مثلا في المانيا وفي كندا وفي انجلترا، الريزلت بتاعتهم في الريبير كويسه جدا، وده اللي احنا شايفينه في الترايل ان الريزلت كويسه جدا قصاد بروسيجر لسه ما كانش هو الوقت ده، يمكن بقى لها 5 سنين موجوده، ويعني برضو الفوليوم فيها ما كانش كبير قد كده. هل يا ترى لو الاوبريتورز اللي بيعملوا مايترا كليب هم مثلا بقى فيري هاي فوليوم اوبريتور، ان هم كل واحد 500 كيسز 600 كيسز وبيطلعوا بنتيجه كويسه يعني من مايترال ريجيرج 1، هل الريزلت بتاعت الترايل دي ان اي اسيوم السيرجن ار ذا بيست سيرجنز لان هم اوريدي هاف 30 years experience في السيرجري. In our MitraClip, first in man was I think 2009. كان التريتمنت يعني ما كانش بقاله 5 سنين، وده باين برضه في الديفايس سيلكشن. لو حضرتكم بصيتوا في السبلمنتري بتاعت الترايل فيري هيتروجينيوس، يعني كل الترايل الديفايسز كلها فيري اولد جنريشن موجوده، وما فيش لحد دلوقتي في الديفلوبمنت يعني في الشركه اب تو 7th جنريشن ان ديفلوبمنت. فهل يا ترى الجزء ده يعني اللي احنا عارفين mitral repair one of the most demanding surgical procedure كسيرجري وبرضه كانترفنشن، هل لو احنا يعني عملنا examination الاسبكت دوت، كان في بيبر طالعه من الناشونال انبيشن داتابيس في امريكا على الاوتكم بتاع الماترال جيرش، هم كانوا لقوا 2 بيك بعد 10 حالات، بيك بعد 300 حاله الاوتكم بيتحسن جدا في الاكسبيرينس اوبريتور. هل يا ترى في طبعا جراحين كتير عملوا 3000 مايترال، جراحين كتير.
شوف الجواب على سؤالك بمختصر. يعني I think you're talking about expertise based RCT randomized trials. I think in surgery I remember I was involved in the off pump versus on pump. And I remember that trial has 4,700 patients, 72 sites worldwide. The request is you have to done at least over 100 cases to be enrolled or to be a recruiting patient. That is very few study would require that. The other thing is I'm going to ask, I think what you are referring to, I think when it comes to replacement, I think an average surgeon should be capable and comfortable doing it. But I think you probably meant the repair when it comes to Barlow disease, P2 prolapse. You want to do, quadrangular resection, sliding plasty, ring plasty, new artificial cords. That is not everybody can do. And if you allow any all comers, all surgeon to come and do that kind of operation, the surgeon will shoot themselves in the foot. They will not have a good outcome. But also at the same time, if you're restricting that to only the expert in the field, to مجدي يعقوب وتيرون ديفيد وديفيد آدم وجماعة اللي في بعض الأماكن, then it's not going to be generalizable. I think you need to have the hybrid of both. To me, is like, again, you're not going to let somebody who's just graduated last month to start enrolling, but somebody with some medium, like 7, 8, 10 years. I'm not sure, we have to read the papers, but definitely I think when you have the operator have experience, is not the same as people who, there's always learning curve. I think it depend on the procedure. I think for surgery, we all talk about 25 to 30 before you get comfortable whenever you start a new procedure. But I think your point is very valid. I think beside the evolution in the medical therapy, we saw it in stents, balloon, bare metal stent, drug-eluting stents. Now, first generation, second generation. Now I see a different clips that Dr. Mohammed showed earlier. When I left the program in 2017, we had one size, and if we cannot grasp, and we have to grasp at the same time, we cannot independently manipulate the clip. And now we have the luxury of 4 different sizes, the different width, and independently you can operate. You can grasp posterior leaflet first and then anterior leaflet. So there is definitely impact on the التطور تبع الاندستري for sure.
هو برضو انا عندي كومنت بسيط برضو يعني كنت حبيت اقوله نقطتين تكنيكال بوينتس. اول بوينت هو بالنسبه لموضوع الاكسس، كان في ديبيت على الاكسس لما يبقى في مشكله في الانفيرو فينا كافا. في اكسس مهم جدا الناس ما اتكلمتش عليه، اللي هو الترانس هيباتيك اكسس، وده موجود مع البيدياتريك سيرجن او بيدياتريك كونجنتال انترفنشنالست بيستخدموه كتير، وبيقفلوا بعد كده زي باي اس تي فلودر او بي دي اي فلودر، والاوت كوم بتاعه مش وحش يعني. ادي اول بوينت. ثاني بوينت هي المايترا كليب، وده كمان برضو احنا في كذا ترايل عليها. يعني مش البوينت بتاعها بس ان احنا نعمل ايدج تو ايدج ريبير، هو احنا بنعمل كمان indirect annuloplasty effect، يعني بنقلل الانتروبوسيري diameter بتاع الميترال annulus which has a positive effect على coaptation outside of the clip region which is also very يعني انا رايي الشخصي ان هو ده ميكانيزم مهم جدا في الميترا كليب، وده ما حدش طبعا بيعرف يعمله غير لما يبقى عنده فوليوم كويس مثلات وفاهم كويس جدا النقطه ديت، وبيعرف يعملها من غير ما يعمل بيسموها يعني مالكو ابتيشن سكندري جيت او مالكو ابتيشن. المشكله دايما ان انت بتركب كليب تطلع سكندري جيت من جنبيه يمين او شمال او في حته ريموت اصلا خالص. دي بتبقى بسبب حاجه اسمها بين ويلينج للكليب، يعني للمايتال فالف ما بيبقاش نون سيمتريك كوابتيشن. فهو دي بتحتاج اكسبيرينس مع الوقت. تقدر تعمل انيولوبلاستيك افكت، تقدر تعمل كوابتيشن في الحته الريموت بره الكليب، وبتحسن الاوتكم كتير.
I think if the intervention cardiology world come up with a way of stabilizing the annulus, I'm telling you from now, even the primary will go. And the reason why surgeon will remain dominant in this field until now is I think the concept that was brought up by Alan Carpentier, the French surgeon, about when you do repair mitral valve, you need to support it by the annuloplasty. الميزه تبع البي 2 ولا degenerative MR, when we do the repair, doesn't matter how much we resect and how much we play with the leaflet when we put it together. When you do the annuloplasty, we technically, if you look carefully at the echo post repair, the whole posterior leaflet become coaptation height. And that is why when you have more than 5 to 7 millimeter coaptation height, that is why your repair is durable. But when you finish, Mahmoud mentioned a very important point earlier. There are some cases where you barely, I've seen cases where edge is barely touching. When we grasp them with the old clip, I would say this guy with this ventricle and this atrium, يعني even if he coughs, probably the clip will come out. بس I think الحتة تبع الانيولوبلاستي stabilization or the annulus stabilization is very crucial for durability.
دكتور عادل برضو عندي
clip.
I have a comment. Excuse
Yeah.
me. Okay, sorry for the interruption. But this is the second time that you mention annuloplasty and the clip. The clip is doing annuloplasty as well. There are many studies, or maybe not for sure, post-clip measurement of the annular size and for the there is remodeling happening after edge-to-edge repair, and there is some sort of annuloplasty is happening as
بس
well.
الpulling تبع الليفلت is putting if you are relying on the leaflet grasping to pull the posterior leaflet anteriorly, I think you're putting a lot of tension. There's a lot of tension, Dr. Muhammad. This is the reason why Alfieri, when we saw him in one of the conference, he said the reason why my result failed when I put even 3 or 4 figure of 8 between A2 and P2, because he said I was stupid. I wasn't putting annuloplasty ring. I wasn't stabilizing. He said if I was putting the Alfieri stitch and I was supplementing it with a ring, like what Alan Carpentier was suggesting, I think I wouldn't be seeing a lot of failure at 10 years as now. But I think his mistake was
the
stitch was not
stitch is
supported by
totally
a ring.
Yes, but the stitch is totally different from the mechanism of the clip. The clip is taking a good piece of leaflet material within the clip, but not only a stitch. That's why, in my opinion, there is more durability with the clip in comparison to the Alfieri stitch.
Potentially,
And
but I think the concept is
Yeah.
probably the same. The concept is you're opposing, but both did not stabilize the annulus. So if you don't,
but I think the key, if you look at these groups, Adil, most of these patients, when you're talking about functional MR, you look at all the trials, the mortality is not great no matter what. So the survival is not 10 years, almost in all case settings. So if you look at the COAP trial, the survival, the 2-year mortality was 50% in the medical therapy arm. It dropped down dramatically to 30% in the clip arm, but it's still 30% at 2 years.
Yeah.
And now they're showing the 5-year data. The mortality in that group is close to 50% and close to 80% in the other group. So these patients are not surviving. But yes, you're right. If you start to do more healthy patients, you need to find some annuloplasty. There's been a lot of development. We did this cardiobands. I've done a couple of these mixed cases, but it's not technically easy. It's very challenging. They withdrew the product. There's the indirect annuloplasty from the Carillon device that really is probably not going to be prime time, and where it goes into the coronary sinus. So they haven't found the right. So we haven't found the right solution for annuloplasty that's reproducible.
وإن شاء الله ما تلقوش يا محمود. إن شاء الله ما تلقوش.
But the one difference I will say, why is clip so different, is we don't need to get as good of a result with clip because the procedural risk in people that do it is extremely low. Surgery in a bad ventricle carries much higher risk. The surgery, even if you get a great outcome, but the patient is a higher risk for mortality in the procedure. Whereas with the clip, the procedure itself has extremely low risk. And so patients do well with the procedure, even if the MR reduction isn't as good or as great as surgery.
Mahmoud, this is the point that really struck me when I was doing the clip. I was like comparing the surgical side, and when I see the team, like we're 4+ and you're like 1 or 2+. Everybody's like, oh yeah, we're stopping. That said, the gradient is 3. We don't want to go to gradient more than 5 because last thing you want to give him a gradient of 6 or 7. And Actually, clinically, the patient will do well if you just bring him to mild to moderate MR. So I go to surgery and sometimes I get a bit of a challenging
Dr.
with,
Adam,
and I said, you know what? It's a 1+. It's not,
Yes, but you are comparing operable patient to non-operable patient, Dr. Adel. This is not fair. These are group
no,
of
no. But
Dr.
patients
what
who
I'm
Adam,
are.
saying, what I'm saying,
Dr.
the
Adam, ما
impact.
تسمعش الكلام بقى.
لا
ما
لا what
تسمعش
I'm saying,
الكلام.
Dr. Muhammad, the impact of reducing the MR, it doesn't have to be, trace. Like sometimes in the
دكتور قام اسمع.
Yeah,
Dr.
دكتور
now I
قام
get your
يدور في
point.
مفتاح ميزان.
when you get a 40,
قام يدور في
60%
مفتاح
reduction
ميزان ده.
in the jet
Yes,
size and the jet
yes,
volume, I think your patient
would
that
benefit.
reduction will prevent him from coming back, will make the medical therapy work more, will let you introduce more medical therapy, will let you titrate your medical therapy. I think overall he will get better.
Yes, sure.
That's my point. I
I
think
have a question to
تمام.
Dr. Adel.
yes.
Sorry, Osama. If you have a patient young, about 50 or 60 years old, with ischemic cardiomyopathy, pump functions 25%, 20%, with severe mitral regurg, symptomatic, with high in NT-proBNP, will you operate on this patient or you will send him to edge repair?
No coronary disease,
Ischemic cardiomyopathy, yes.
عنده coronary on angiogram.
لا coronary angiogram ما اتعمل وهو he has already treated with stents and doesn't have
عنده
to
رتم.
anything more.
يعني ما عندوش any residual significant coronary disease.
Exactly.
Treated
رتم
he's 50 years old وما عندوش. This
Ejection
is
fraction 20%,
20%.
ischemic cardiomyopathy after myocardial infarction. Coronaries were treated with stents and now he's suffering with rehospitalization and high NT-proBNP.
He's symptomatic. I would not. I mean, depend on the if the ventricle is really dilated, 7 or whatever, and it's multiple infarct, and I think
You're not touching this patient. You're sending him
I'm
for
not
TEER.
touching this patient. I am not touching. If
This
it's
is,
truly
I think
27,
this is.
no.
I got
I'm
to
not
the
dumb,
point.
Mahmoud. I'm not gonna say it. No, but the age might be something that I would require heart team, and
Yes.
because if you send him, like I'm telling you, there are patients that I've sent to the heart team to the clip, and the valve area is 3.2. He's a small body. Oh, he's this. I mean, the EF is 30, 35. We took this patient to surgery and we did a
Yeah.
cordal split
Of
replacement.
course. That's
But
why
I'm
you have a
sure,
heart team.
I'm sure in this patient, I would not be salivating and jumping on him. No.
I think this is a good message, and I think operable patient should be operated upon. But this type of patient is exactly what we are
Regardless
discussing.
the
This
age.
is irrespective of the age. It's not a matter of age. It's a matter of patient disease comorbidity, and I think this is the message that we have to deliver. The patient who is not operable, irrespective of his age, should be treated with edge-to-edge repair.
المسج الثانية يا دكتور محمد, you won't have a 10 years outcome if you don't have a 1 year outcome. عرفت؟
Exactly.
البيشنت هادو
Yeah.
you get confronted with والبيشنت the referring cardiologist start getting itchy و uncomfortable about your decision. لما تشوف له تقول له بالله هو 50 ودنس hemiplegic stroke وعنده AFib وعنده clot في الابندج, هذا forget about 25 years outcome. Let's just make it simple, because you know what the patient protoplasm what dictate what we should do.
I think Osama had a comment as well.
Yeah.
تماما دكتور محمد, هو في برضه كان انا من واحد من اعز اصدقائي, يعني هو مايترال سيرجن واحنا دايما بنتكلم كتير عن المايترال فالف. فهو في بيبر طالعه يعني جديده في امريكا في الجاك انترفنشن, الاكشوال مايترال فوليوم في الاماكن اللي فيها تير بروجرام بيزيد, السيرجيكال فوليوم بيزيد لما يبقى فيه تير بروجرام, لان هو الجراح بيقدر يقبل حاجات ما كانش يقبلها قبل كده, لان هو عنده تير بروجرام يقدر يغطي عليه, والعكس.
والسكريننج افضل,
والسكريننج افضل تماما. انت بتبقى سنسبل ان انت تدور على مايترال تراكاستيك ومايترال تراكاستيك بيشنت فور يور كلينيك. فالسيرجري والتير they are not competitive at all. هم السيرجري والتير دول جروب اوف بيشنت, والتير جروب انذر جروب اوف بيشنت كانوا قبل كده بياخدوا فوريزس 20. That's it. هو
بالعكس،
يعني
هو مصداقية لكلامك، احنا بالعكس الاسكيميك دول we would like not to see them. مشكلتنا انكم دخلتوا على البرايمري والديجنراتيف، هنا حيصير
Still primary study is going on. The
I
primary
know I know،
trial is going
بس
on. We are
الاسكيميك
part of
we're
this
not
study.
competing. مشكلتنا مع مثلا التافي مثلا. I think there's an area of competition. You can tell language will vote. Although TAVI environment, because there are so many patients, so many bicuspid, so many coronary disease, so many root, many different. لكن الميترال ischemic او السكندري عايشين في عالم لوحدهم. I don't think they call us many times. يعني هم actually they're relying on us to send them the patient.
Yeah.
تماما هو ده اللي بقصده. وفي نفس الوقت احنا بنستفيد من السيرجن، والسيرجن ده في كتير من المرضى هم السيرجن ما بيقدروش يميزوهم. وانا جالي مرضى من سيرجيكال كلينيك متحولين
Yeah.
عشان هو الكارديولوجي اللي عنده لو فوليوم ما بيعرفش يعمل الحالات ديت، وبعتها لي الحاله وانا عملتها.
Yeah.
ف السيرجري والتير از نوت كومبيتيتيف خالص بالنسبه للبرايمري كده. هي كل ده اوبريتور ديبندنت. يعني هل انا لو في برايمري ام ار في مريض 70 years old وستريت فورورد كيس بالنسبه للكليب، انا ممكن احط لكم حاله دلوقتي ان شاء الله احطها على الجروب يعني، وستريت فورورد كيس، وانا ما عنديش سيرجن كويس يقدر يعمل ريبير للحاله، خلاص، او الاوت كم بتاعه هيبقى ريبليسمنت. الريبليسمنت از فيري جاد فور ذا فنتكل، ان هو بيحصل المايترال البابيلري ماسل فانكشنال بتروح خالص بعد ما بيحصل ريبليسمنت، فاحنا عايزين ريبير. انا اي دونت وونت ريبليسمنت، انا لو انا مريض انا عايز ريبير مش عايز ريبليسمنت، خلاص. فهو الفكره في ان هو اوبريتور ديبندنت كسيرجن وكاوبريتور كليب، مش باثولوجي. والمريض هو 50 سنه بس هو اللايف اكسبكتنسي بتاعته 5 years،
شوف
و50 سنه
دكتور أسامة، أنا هقول لك حاجة واحدة من الحاجات اتعلمتها في ال15 سنين اللي فاتت. التافي made the cardiac surgeon I would say smarter. They pushed the surgeon to do better job, root enlargement, become more aggressive in putting a bigger valve, doing much better work at the aortic root surgery. الميترال I think يعني شوف يعني حتى الميترال الفانكشنال تو حاليا in our group احنا we are 6. من النادر يعني traditional teaching you always have to preserve the posterior leaflet. Now if you have a functional MR you actually have a dilated annulus. When you size your valve you can actually size up to 33 tissue valve without any difficulties. We are refrained from excising any leaflet. Now we're starting doing what we call a chordal sparing replacement. يعني انت الايشو تبع change in the sphericity of the ventricle وال LV function goes down by 1 grade, you don't see it anymore, at least in certain center with experience. In our center we don't excise anterior leaflet, we preserve a primary chordae بتاع anterior leaflet, we don't excise, we just anchor them into the suture. And
what
in
about
that way, yes.
What about LVOT obstruction if you preserve the anterior leaflet?
What we do in that particular condition, you excise like at the basal segment of the leaflet, like يعني زي elliptical shape, لأن البرايمري chordae attached to the free edge. Anterior leaflet doesn't have a tertiary and secondary chordae, mostly at the free edge. فأنت بتاخد الsuture into the annulus and then into the free edge and you placate it. So there's no protrusion of the leaflet into the LVT. It does not. مش زي انتم مشكلتكم مع transcatheter valve anterior leaflet cause LVT obstruction. We don't have this. So you reduce the height of the anterior leaflet by excising the part that does not have cords, and then while you're placing your suture, you anchor it into the free edge. So you preserve both and using it as a pledget so that you actually prevent any parvalvular leak. حتى
Very
شوية
nice.
beyond
Technical. بس احنا عندنا برضو اللامبون، عندنا برضو اللامبون.
لامبون زي هذه تبع اللفت مين بتاع تبع لما تكون انت ديسبرت، ايش اسمها ال يعني لما تكون بتخش لللفت مين وايش ليش العمليه نسيتها يعني. لامبون هذه للميترال في الفالف
الميترال
هذه
في اللي قصدك على البازيليكا في
بازيليكا.
التالي.
يا سلام، وما ادراك ما البازيليكا. بس
تمام احنا
والله
ككارديول
التوبيك تبع الريبليسمنت a lot of people they have this notion. I understand الريبير. If the patient's valve is repairable we all repair. الريبليسمنت ما يمشيش الا روماتيك endocarditis perforated ولا يعني واحد مش يعني
بس to be honest with you, in our region, Egypt, North Africa, Libya, I
yeah.
think most of the surgeons are doing replacement more than repair because they have some,
الباثولوجي
no, irrespective of the pathology,
البرنسبل.
they have a problem with the patient after repair. If the patient have recurrent MR after 2 or 3 years, he returns to the surgeon and says that your operation has failed and I have again the problem. I think that's why they do more replacement irrespective of the pathology more than repair.
Okay.
I don't know if you
Technical
have
issue.
surgeons here. Maybe I'm wrong. If any surgeon can comment on this point
The
from Libya
replacement
or from
hard
Egypt.
technique. دكتور محمد replacement repair hard technique مش not every surgeon can do it.
Mhm.
زي ما
عبد الرحمن,
قال
are you a surgeon?
قصة
عبد الرحمن,
النقطة
are you a surgeon?
No, I am not surgeon, لكن أنا نشوف فيه
Well,
حسب my
let me
experience.
tell you about from
نشوف
my
ما احنا عايزين
perspective. I'll
حد
tell you
شغال.
two things, okay? And yesterday actually I was doing a simulation teaching about mitral valve repair, quadrangular section and all that. The problem is, I think it depends on where you trained. I was lucky trained in an era where there was 3 surgeons trained in Toronto with Tyrone David. They were hired in our center and they all do mitral. 1 open sternotomy, 1 mini mitral. البرنسبلز if you ask me the mitral valve repair اسهل من الريبليسمنت especially mechanical valve. Mechanical valve الليفلت بتحصل especially if you have a small ventricle و dilated atrium و MS و rheumatic nightmare. I hate replacement. الريبير especially if you give me P2 او posterior leaflet, yes ممكن لما تكون بارلا وباي leaflet شوية الشغل معقد وبعدين بنخشوا في resect versus respect new chords كذا. بس الريبير is much more predictable و much more if you follow P2 prolapse just a quadrangular.
But the recurrence of MR is higher.
البرنسبل
دكتور
no
عادل.
الريكرنس MR no. If you follow, you had a 25 years of data that shows the recurrence more than 90%, 95% no recurrence if you follow the Alan Carpenter's guidelines.
دكتور عادل.
Proper repair, if you have a P2 prolapse, if you have a fibroelastic deficiency, don't repair rheumatic or perforated endocarditis وكذا وتقول لي repair recurrence. Yes, if you try to repair a different pathology, your failure will be high. If you want to repair every barlow, you will have a high failure. بس بنحكي على simple. Let's start with simple. P2 prolapse, myxomatous mitral valve, عندك واحد عنده فليل P2 وشوية كليفت هنا وعنده dilated annulus وجود LV, تعمل له 34 36 ring و P2 quadrangular section, trace MR. I guarantee you يعني I can bet you money before it when I look at the echo. But I think it comes down to your exposure during training, how comfortable. In general, people look at the mitral valve شوية with خوف زايد على اللازم. I think I find mitral valve much more entertaining.
وبرضه economic part plays a big role. As I told you, in Egypt and in the Arabic countries, they try to do more replacement than repair. I don't know if you, as you told, this is related to the experience, or maybe because of the economic part, the patient sometimes pay by himself for the whole procedure and he cannot afford this in 2 or 3 years again. That's why they try to make a more prolonged procedure like mechanical valve or tissue valve in old age, but replacement.
You're harming the patient, Dr. Muhammad. If you look at it, ideally, you shouldn't be having patient coming back in 2 to 3 years. Second, I think if I have a 45 years old or 50 comes with a P2 prolapse ونعطيه mechanical valve, I am not providing good service. I'm providing a patient, now I'm dropping his LV, I'm giving him mechanical valve, I'm giving him a risk of endocarditis. You're not doing him a favor. Trust me.
عشان كده كنت حابب نشوف الاوبينيون بتاع يعني اي سيرجن موجود معانا النهارده في الجروب لو كان يعني يقول لنا الايديا بالظبط ايه ليه هم بيرجعوا more to replacement than for
بالضبط
repair.
مش عارف انا هل هي lack of training او lack of interest، ولا على السريع على
هذه
السريع
نقول لك
وخلصني الله اعلم، مش عارف الاسباب،
دكتور
لكن
عادل، قصة
technically is not
التنشن
difficult.
دكتور عادل معلش لو
ايوه
سمحت، قصة التنشن هي وقصة الربطة متاع انك انت هاو تو يعني هاو تو ستيتش وقداش التنشن اللي تديرها، هذه راه مش كل سيرجن يقدروها. هذا بنشوف فيه يعني، حتى نناقش فيهم وندرس معاهم تحسهم مش ملمين بهالموضوع.
بس وين ما هو هي مشكله، ما تحكي لي على
انت
ليبيا
تقول
انت.
اسهل، لكن هو زي ما انا زي ما قال لك دكتور محمد، يعني فعلا نشوفه في الريبليسمنت بس ما نشوفوش في الريبير.
بس
هذا
بتشوف
ما
فيها
واقع.
شنو الباثولوجي، هل الباثولوجي كلها ديجنراتيف ولا كلها روماتيك؟
irrespective of the pathology.
irrespective.
irrespective of the
هل
pathology.
هي 50 50 20 80؟
شو بنقول لك
لان في العالم
شوف،
الغربي الديجنراتيف از مور
10%
كومن، في عالمنا
من شو
احنا
يسموه ريبير
اليونجر
بالنسبه لي
والروماتيك از
من ماي
بريدوميننت.
اكسبيرينس.
مش عارف.
زي ما قال لك دكتور اسامه سيرجن، هو
لا
كان
لا
أسامة
مش
يجي
سيرجن،
بيشتري
احنا
كارديولوجيست.
كارديولوجيست.
كارديولوجيست. ما في مش ما
لا
فيش
انا ارجع
كارديو.
لنقطتك، هي احنا بنتكلم برضو اوبريتور فيرسس اوبريتور. هو المايترال فالف ريبليسمنت من ايد دكتور عادل غير المايترال فالف ريبليسمنت من ايد دكتور اكس ابسلون من جنوب افريقيا مثلا، يعني بلاش منطقه بتاعتنا خالص يعني. فهو الفكره ان الاوت كام الاوبريتور هو 50%، والاوت كام مرتبط بالاوبريتور سواء كليب سواء سيرجري. وبالتالي احنا وي وونت سيرجن، احنا مش عايزين السيرجن اللي هو سيلكتيف ياخد المريض اللي هو اونلي مايلد برولابس جود ريفيرابيلتي وياخد يطلع نتيجه اوت كام بعد كده يقول لك انا الاوت كام بتاعي ممتاز. لا انا عايز اول كامر سيرجن، عايز سيرجن قوي اجريسيف. بالعكس انا بحب اشتغل مع سيرجن قوي، لان السيرجن القوي بيقبل كل الحالات وانا بقبل كل الحالات. مفيش ولا مريض برجعه البيت واقول له روح موت في البيت، ما بيصير ابدا.
شوف دكتور
احنا وي وونت.
اسامه، احنا مثلا if I can classify الميترال فالف سيرجري، تقدر تبداها من بسيط لمعقد. يعني انا نقول لك مثلا بي 2 برولابس از اسهل عمليه، اوكي. بعدين نيجي للاندوكاردايتس والروت ابس والابسس وكذا، اوكي. بعدين نيجي للاكستريم اللي هي النايت مير تبع السيرجن لما تبعت لي حد with severe MAC، اوكي. Even the severe MAC we don't turn them down, and a lot of them they don't have a lot of good alternatives. فيجيك واحد عنده سيفير ماك، سيفير مس، سيفير مار، اوكي. لا هو بتاع بالون فالفوبلاستي ولا هو بتاع كليب، ولا كله مسكر. الفالف اريا 2.1 ولا 1.5، والجريدينت 22، وبيشنت 79، ويقول لك مايترال فالف. تقعد ديكالسيفيكيشن وباتشنج ومش عارف ايه، تقعد all day. يعني these are the extreme. الميترال valve could be a nice and friendly case و could be a nightmare. تقعد you patching the posterior annulus و undersizing the valve. البوينت هنا I think each surgery is different. I think if you see a surgeon who does one mitral valve every 2 years, you should not be sending that patient. I think even the center، في سنترز حوالينا بتاع كابج اوف بامب بس. في سنتر احنا بنعمل الراس، الروت، البنتل، بنعمل 130 mitral valve a year، 508 تافي، 45 كليب، 1600 كيس open heart surgery. فالكارديولوجي اللي حوالينا they feel comfortable. تبي اوف بامب موجود، تبي ميني فيه، تبي راس موجود، تبي ارش موجود، تبي تافي، تبي تبي elephant trunk موجود. ف I think you need to know where you send your patient. وهذه الجوب اوف ذا كارديولوجيست. احنا في اخر التانل at the end of the tunnel لما يجيني المريض I have to deal with him. مرات تبعتي لواحد is not doing. I've seen a 19 aortic valve put in a patient that has easy 25 sizer. Easy, you put a 25 tissue valve and I see it 19.
تمام، يعني
Still,
احنا
even
يعني
in Canada,
في
even
الجراحه
here.
الهاي كواليتي سيرجري، انا لو عندي مريض هاي كواليتي، لو عندي سيرجن هاي كواليتي ابعت له فورا المريض. طبعا هو لو المريض يستفيد من الجراحه طبعا المريض الجراح. انما انا بقول لحضرتك الريل لايف زي ما بتقول مش معظم السيرجن. انا احيانا باجبر على ان اشتغل مع سيرجن انا عارف ان هو ما بيعرفش يعمل. انا والله العظيم بعت حالات لدكتور محمد سعد في مايترال فالف رينج ومايترال فالف الفالف مايترال عشان السيرجن بتاعنا رافضها خلاص، وبعتها 500 كيلو تروح تعمل جراحه عند الدكتور محمد سعد، مع ان ده مستحيل في المانيا. المفروض ان انت يبقى عندك يعني على 70 50 80 كيلو مركز بيعمل، بس هو السيرجن اللي هو بيعمل اول كامر ده مش هو ده الستاندرد، ده الراريتي. الافريج سيرجن في المانيا مش كده خالص.
yeah. لسه عندنا سؤال من سمر جلول. سمر جلول، انت رافع ايدك بدري.
ايه، اهلا وسهلا.
ايوه، مرحبا سمر، تفضلي.
بارك الله فيكم على المحاضرة، الحق ما شاء الله أبدعتوا. لكن هو مش عارفة، أنا فرحانة وزعلانة في نفس الوقت. إزاي حالات الإسكيميك هارت ديسيز اللي هم السكندري، هذا أكتر حاجة يعني إحنا نواجهوا فيها في الحالات الأو بي دي، يجونا بكمبنسيتد هارت فيلير يعني، ومعهم سيفير ام ار. لما هنا نديروا الدكتور يدير لهم انجو يلقاهم فور كابج، يعني مرات تري فيزل ديزيز
yeah.
معهم سيفير ام ار. تو الحالات هذه what do you think it is for repair for replacement
الحالة اللي تجي ب سيفير مار وعنده تري فيسل ديزيز،
ومع
هذا
اسكيميك
سكيمك
يكون
ايه. عادة
سكندري. هو
الريبير
يبغى
فيهم
سايز والال سايز نورمال، يعني جاي نتيجة
شوفي.
الاسكيميا
لو
كيوت
it is true، لو it is truly true severe، يعني بكل
وسايز.
الكريتيريا انها سيفير. كان هي سيفير
إيه.
وعنده تري فيسل ديزيز، he will go to surgery. الدسكشن بعدين، لان معظمهم اسكيميك، يعني الفنتريكل is a little bit remodeled، الليفلت are tethered pushed down، الابابيلر muscle displaced. الريبير in this condition is not durable. ف in this patient I would do cabbage whatever number of bypasses depend على patient profile والage، cabbage 3 4 whatever، وحندير له cordal sparing replacement. كانوا مثلا
طب
فوق 65
بس
حندير
دكتور
له.
عادل، I have understood the question
حالة
another
تو لها
way.
3 أسابيع
I
لما
think she
دزيت
needs.
الجراحة، على أساس إنه هو قال فور ميديكال تريتمنت والكبج يدروا له بي سي آي يعني. فأنا
هو
استغربت الحالة يعني من القصة.
يعني
ممكن
يعني
يكون
الكوروني ديزيز تبعه، هل هي سنجل فيسل، هل هي
3
3
فيزيت الار سي اي توتالي اكلودد،
ال اي
ال
دي؟
دي حتى هو في البي دي اي في ستينوسيس، ال سي اكس حتى هو عنده 70% حتى هو.
ال اي
فكان
دي
ال اي دي المين
لفت
كويس
مين، انا
في
ال اي دي ديزيز حتى هو ولا مش؟
اللي عنده
اعتقد يا دكتور
اوستياليز.
عادل
كيف؟
اعتقد يا دكتور
فكانت
عادل
الحالة
السؤال هو
كومبليكيتد، والال في
السؤال
فانكشن
هو
45.
في الحاله اللي زي كده ممكن يكون الميترا ريجيرش هو papillary muscle ischemia induced. The question, can we treat only the coronary artery disease depending on ان احنا نعالج الاندرلاينج باثولوجي اللي هو البابيلاري ماسل اسكيميا، ولما تتحسن هيقل الميترال ريجيرش؟ ده اعتقد السؤال.
Yeah, this is the question.
أنا سؤالي قصص يعني ممكن هل هو فور ريبير هل فور، هل
شوف
هو
يا
فور
سمر، لو انت المريض عنده كوروني ديزيز amenable to angioplasty وما عندهاش كريتيريا اللي فيفرن كابج،
لا
ممكن
هو فور
بدون
كبش.
لا، هو لو عنده حد
ما
يدير
هو
له
مش
بي سي اي
إيه،
باهي
نعم.
ويقدر يدير له بي سي اي with good result، you want to
مم.
relieve the ischemia to see بعد ما انت relieve الاسكيميا الامار هديه ناتجه من الاسكيميا ولا لا. لكن في
مم.
نوعيه يجيك واحد left main 80% calcified vessels 3 vessel disease وعنده EF 35 or 40% وعنده severe MR، هذا ودايبتك باهي. ما هو السيناريو يختلف من حاله لحاله. لو جاني واحد بالسيناريو هذا 3 vessel disease diabetic LV dysfunction left main وعنده moderate to severe MR functional وعمره 60 سنه، if you refer him to me I will take him to surgery, do cabbage 3 4 وندير له mitral valve replacement.
طب سؤال يا
لانك
دكتور عادل،
لو
لو
مايل
هل
تو مودريت ام ار تقولي والله ريليف الاسكيميا، وحتى لو اديت الجراحه
تسأل
مش
إيه عن
لسه ماتت.
تسأل على
لكن
الاسكيميك مار.
لسيفير، لو انه سيفير مايتر ريجرجيتيشن بروفن وديسبايت التريتمنت قاعد سيفير وقاعد البيشنت سيمتوماتيك وعنده 3 فيسل
هو
I have to
هو
address both.
الميديكال تريتمنت ويل يعني نون سيمبتوماتيك، يعني طلع من البلمونري اوديما ويل بت الميديكال تريتمنت يعني فهمتني.
السؤال يا دكتور عادل،
الميديكال
هل
تريتمنت is optimizing to
ديوريتك
provide him some
زرت
time.
يعني ديوريتك كنت جاست ديوريتك
هل
وبيتا
الرينج سايز يفرق معاك في الديسيجن؟ يعني لما يكون تو بيشنتس، واحد الرينج بتاعه دايليتد، ده اكيد فور شور هتخش تعمل له باي باس كابج بلس الانيولوبلاستي. بس لو كانت الرينج مش دايليتد في العيان دوت، وهي الموضوع كل المشكله اسكيميا بس في البابيلاري ماسل، في الموفمنت بتاعت البابيلاري ماسل، هل ده برضه هتعمل له حاجه للمايترال ريجيرج ولا بس هتحسن
شوف دكتور محمد، أنا I would rely on the pre-op echo and I still have intra-op echo. لو intra-op echo with good hemodynamics قاعد عنده significant MR jet
هتحط رينج؟
reversal of flow in pulmonary veins and blunting of flow وعنده wide vena contracta وعنده كل البارامتر تقول لي هدية at least moderate to severe MR, I'm not taking chances. I would replace it. والpatient is a low risk profile. لو البيشنت وصارت لي كم من مرة 79 80 ونفتح ونلقى ليفت مين وكالسيفايد اورتا ونلقى مودريت سيفير مار، اعمل بشتري اوف بامب نو تاتش تكنيك للاورتا، هارد سترينج، ليمة تو ال دي واطلع كلم التليفون جماعة التيرز هذه 80 years old درت لها الريفاسكولايزيشن عندها مودريت سيفير مار I don't want to do circle rush to replace لاسنج اورتا واو القصة الحزينة. Can you see him for consult to do؟ يقول لي get him discharged, optimal medical therapy, now you revascularized, let's see him
3
in 2
months
months,
reevaluate.
we'll do the clip later on if he's eligible. لكن لو تعطيني واحد low risk young والميترال is moderate to severe or severe MR يعني يعيط عياط severe MR reversal of flow والانستيجا بيعيط ولا كارديولوجي مكلمين اللاب كله طلع فوق يقول لي لا this is severe don't leave this mitral valve. I would replace it. I would replace it. Yeah.
Clear answer.
Yeah.
I think we're running out of time. ممكن يعني we can go through the questions to answer the question and then we can close the session. What do you mean?
Sure. وهو
أنا يكون ستراكشر الحرب وموف السيرجيكال، لأن معظم الحالات تقعد يعني كلهم ستريت فور سيرجري، لكن على الميديكال تريتمنت ما تقدرش تدير لها شيء يعني ونوت افيلبل ممكن سيرجري.
يا سمر وضع ليبيا وضع صعب يندار له لان الميديكال ثيرابي محدود. لو هو اذا انا جود ميديكال ثيرابي sometimes it buy him some time to get him باش قرر له decision making يطلع يمشي لتونس يروح لمصر يروح للاردن. ففي ليبيا وضعنا شويه حرج شويه في بعض الحالات المعقده يعني للاسف يعني.
شكرا بارك الله فيك.
ولا يهمك. في حد عنده سؤال تاني؟ مش عارف الشات بوكس يعني هذه
الدكتور محمود بن هاني، انت ممكن تقولي السؤال بتاعك لو تحابب.
محمود بن هاني ما زال معانا؟ I can see I'm also a cardiologist and our hospital, our surgeon always try to repair the valve like you mentioned primary MR without endocarditis or perforation and we do after doing a CT to exclude calcification of the organ. I think more of a comment rather than question.
Okay.
We have to think also as a cardio MRI in these cases. In this case.
السلام عليكم.
أيوة السلام ورحمة الله.
يعطيكم العافية جميعا، ما قصرتم. كان هو عبارة عن كومنت، كنت يعني أنا نفس الشيء كارديولوجيست، وكنت هو كومنت بالنسبة ليك دكتور إنه نفس الشيء بالسيرجن بيحاولوا يسووا ريبير زي ما أنت ذكرت، بس بعض الحالات لما يكون في عندك الكالسيفيكيشن اوف الاورتا بيحاولوا انه ما بيقدروا يسووا، او انتوا اللي بتعرفوا اكثر منها انه صعب يسوي الواحد ميك اللي هو المينيمال انفيزيف ريبير. فعلى الاغلب اذا كان اليورو سكور عالي ولا هو نفس الشيء بنتكلم انه هاي ريسك فبيحولوا على التير حتى لو كان برايمري. بس عاده هو اللي هو في الميك اكون في المستشفى اللي احنا نشتغل فيه وعلى الخبره اللي عندنا اياها، ميك في البرايمري هي التندنس تبع اغلب السيرجن.
تحكي على سيفير mitral annular calcification ماك اللي هي سيفير mitral annular calcification؟
لا قصدي لما يكون، قصدي في المينيمال انفيزيف
mitral Yeah,
مايترال.
with the right mini thoracotomy. Yes, yeah, we
صحيح
yeah,
صحيح
yeah,
صحيح، هذا اللي قصدي فيه. نعم.
راديو.
yeah. That's becoming the standard for isolated mitral. Like in our center, anybody who has an isolated mitral, he goes through a right mini thoracotomy through the fourth intercostal space, and we do.
نعم، هذا اللي أنا قصدي فيه. نعم، هذا قصدي فيه.
And that what makes mitral valve surgery more attractive, because if you can avoid stenotomy, it makes, that's why I think mitral valve surgery is still alive, is because people are doing it through less invasive access, robotic. In some big centers, they even do it robotically, which is a big advantage. But يعني try to avoid the stenotomy if possible.
صحيح، شفت بعض الفيديوهات أنا في المستشفى يسووها في الروبوتر.
Yeah.
بس بصراحة يعني أنا مش سيرجن، ما عندي خبرة
في لايبزيج، انت لو في Germany, Leipzig is a big center. I went there in 2008. I watched a meeting there. Leipzig, they do a very good job. And I mean, most of the centers in Germany, in Europe, in Brussels, in France, they do a lot of robotic and minimum invasive surgery for mitral for sure. In fact, France is the godfather of mitral valve surgery.
إن شاء الله.
Okay. Anybody
الله
else?
يعطيكم العافية جميعا.
شكرا. دكتور محمد تقريبا we are رجعنا I think we did a better job than PCR.
من البداية رجعت.
I think this was a very nice meeting
لكن
really.
يا دكتور محمد قاعد ما
دكتور عبد
اعطاناش
الرحمن
التريكس بتاعها هو. دكتور
بتاع
محمد
الايه؟
ما
نعم.
اعطاناش التريكس بتاع الشد، قوة الشد اللي دي يربط بها.
يا ودي
هذه ما
الشدة، انت
اعطاناش.
لو كانك في الجراحة تنقولها لك، انت بتسمعها عن قال عن مش هنقولها لك.
تفكر لما انا سألتك عليها اول مرة في الجروب.
ايوه تمام، صح.
لا الشدة هذه تبي شو اسمها، تبي قد قميزة وتبي حالة وتبي demonstration. بس لو ما فيش question we can conclude يا دكتور محمد والبقية. يعني تقريبا everybody has left probably. We don't have as many people, probably everybody's gone sleep. I would like to thank everybody for being part of this event today. I think by either presenting or asking or listening or interacting. شكرا للجميع من جميع أنحاء ليبيا ومصر ومن جميع أنحاء بقاع العالم اللي join us today. It was a pleasure having you guys around, and hopefully we can do more of these sessions. I think the main purpose of to try to trigger discussion, try to stimulate, and try to get the youngster to start thinking in the right path and the right direction, knowing that what's going on around. شكرا جميعا دكتور محمد، سعدت بلقائك وبدسكشن معك، وكان لي الشرف نكونوا جميعا في المحاضرة، وإن شاء الله الجميع استفاد. ولو في أي أخطاء أو تقصير منا definitely wasn't on purpose. We try to do our best as much as we can.
انا بشكرك جدا دكتور عادل على الدعوه وعلى اللقاء الجميل دوت، وعلى يعني التفاهم ما بين الكارديولوجيست وما بين السيرجون في الهارت تيم. وهو دوت المفروض نكون عليه دايما، ان الموضوع مش قصه خناقه على البيشنت، الموضوع قصه ازاي البيشنت get the maximum benefit of both interventional cardiology and surgery. و I think الموضوع كلير، يعني البيشنتس along especially في الاريا بتاعت الميترال والترايكاسبيد. لو العيان اوبرابل يبقى احنا اتجاه الاوبريشن، لو العيان اوبرابل ساعتها هنفكر في الايدج تو ايدج ريبير. وطالما السيرجون وايز في الديسيجن بتاعه، اعتقد، لان انا دايما شايف دايما ان الانيشيشن لازم يكون من اتجاه السيرجن. لما السيرجن يقول انا العيان ده مش حابب اشتغله، او العيان دوت هاي ريسك بيشنت فور اوبريشن، ساعتها يكون الكارديولوجيست هو اللي الرول بتاعه بعد كده. فاعتقد الدنيا واضحه وكلير، بس محتاجه حد يكون فير ويز وايز ديسيجن يعني.
والبوينت الثانية اللي أنا عايز especially in this field, الفيلد هذا still growing. When you read
Exactly.
literature, when you read the studies, be very careful. I think know what are the criteria that they were included. So I think you have some, I think we highlighted some of the criteria that you should use when it comes to when you think of referring the patient to the treatment, because you don't want to be just dumping every patient with MR to a certain intervention. So I think hopefully this will help people to at least know some of the tricks and some of the criteria as to when and when not to refer a patient for intervention.
ان شاء
شكرا
الله
جميعا.
المره الجايه تركسب ان شاء الله دكتور عادل.
ان شاء
دكتور
الله.
محمد
ان شاء الله.
دكتور محمد شكرا لك وشرفتنا وبارك الله فيك.
شكرا دكتور عبد الرحمن، تسلم يا رب.
سمحنا عليك، انا هيك درنا لك شوي.
بارك الله في
تحت
الجميع
امرك.
وتحياتي والسلام عليكم. يلا. تحياتي.
مع
شكرا
السلامة.
دكتور عادل، بارك الله فيك، شكرا على
نور
الإضافات.
نور.
شكرا لكل الحضور إن شاء الله.
يلا.
منورين.
مع السلامة.
السلام عليكم. السلام عليكم.